Okay, great. I think just in the interest of time, we're going to get started while everybody comes in. Thank you all for joining us this morning. We really appreciate it, and we're excited to have a great morning of talks. I'm just going to quickly introduce our faculty and our sponsors this morning. We're so greatly appreciative of all of our expert faculty today, and I know we have a great lineup of talks for you. We're going to hear from Dr. Ben Harun, myself, Dr. Kayal, Rose Lipner, and Dr. Pazer. We also wanted to extend a thank you to our sponsors this morning. We couldn't do it without their support. And I also wanted to extend a big thank you to Erica Krasny for helping to organize this. I couldn't have done this without her help, so greatly appreciate everything she did. So this is the agenda for the morning. We'll start off with each talk. There'll be about 20 minutes with a 5-minute question answer period. Please feel free to unmute yourself during that question and answer if you have anything you'd like to ask. If we don't get to your question during that period, please put it in the chat and we'll certainly answer them throughout the talk, and we'll be monitoring the chat throughout. So with that, thank you so much, and we'll get started on our first talk. Perfect. So I hope you can all share my screen. I'm Dr. Stephanie Gold. I'm an assistant professor of medicine here at Mount Sinai, and I specialize in nutrition and inflammatory bowel disease. And I wanted to take the next 15 to 20 minutes to talk to you a little bit about the management of obesity in our patients with IBD. We'll talk about lifestyle changes, novel therapeutics, and the impact of obesity that we have in our patient population. You don't need me to show you this slide, but as you all know, the epidemic of obesity is absolutely rising in this country, and you can see this dramatic change from the 1990s till 2022. Unfortunately, this epidemic is continuing to rise, and it's estimated that by 2030, about half of the population in the United States will have a BMI over 30, and about a quarter will have a BMI over 35. And so this is really an epidemic that is affecting all of the patients that we're seeing in our clinical practices. Now, with these rising obesity rates, this has certainly impacted our patients with IBD, and what was traditionally thought of as a disease that caused malnutrition and undernutrition, we're seeing rising rates of obesity as well. The current literature estimates that obesity impacts about 15 to 40% of patients with IBD, but unfortunately, these studies are from the early 2013, 2015 era, and so therefore these studies are probably not accurate anymore, and we think that the rates are actually higher. In addition to this percentage, another 20 to 40% are overweight, and so therefore this is certainly something that is impacting all of our patients. We think of obesity as a state of low-grade chronic inflammation, and in patients with a systemic inflammatory disease, this brings great interest into how obesity impacts both the pathogenesis of IBD, as well as the disease course and the outcomes for our patients. And despite the rising epidemic of obesity in our patients, there's very low utilization of obesity pharmacotherapy, and we're really trying to help educate and bring this to light so that our patients get the care they need. Obesity and IBD is associated with various adverse outcomes, including more severe IBD phenotypes, higher amounts of strictures and fistula, more frequent flares of disease, higher rates of surgery, more needs for hospitalization, and when they are hospitalized, longer lengths of stay, higher hospitalization costs. A couple of studies have showed that obesity and visceral adiposity are associated with poor response to biologics. And while these studies specifically looked at our TNF inhibitors, we suspect that it's probably similar across our medications. And in those patients who do ultimately need surgery, we see higher rates of surgical complications, longer operative time, more blood loss, increased resections, and postoperative leaks. What's interesting is that these patients, when the studies looked at obesity, they looked at BMI, and many of these studies were actually negative and said there was no association between BMI and adverse outcomes. But what was really interesting is we realized that it is not the BMI that is the target, but it's the visceral fat that is actually causing these that's associated with these adverse outcomes. We know that visceral fat is not just anatomically different from other fats, such as subcutaneous fat or preperitoneal fat, but it's also hormonally different. It secretes TNF and IL-6 and other adipokines and cytokines that are pro-inflammatory. And so therefore, this is actually should be our target when we're treating our patients with IBD. This is a very standard algorithm that's available for obesity management, starting with lifestyle modification, moving up to pharmacotherapies, endoscopic or endobariatrics, and then bariatric surgery. And as you see on the bottom, the indications for these interventions based on BMI. I don't use this kind of algorithm for obesity management, and I prefer using something that looks like this, where lifestyle modification is part of all of the interventions we do. But as you will see, it is often not clinically significant amount of weight loss, and so therefore we need another intervention. I also like this diagram better because you show that you can have overlap between the different procedures. So maybe a patient who's had an endobariatric procedure has reached a stall in their weight loss and starts on a pharmacologic therapy. And so it doesn't have to be one or the other. They're not distinct entities. They should be used in combination. During today's talk, we're going to talk about lifestyle modifications in IBD. We'll talk a little bit about pharmacologic interventions, including our GLP-1s, and then we'll briefly discuss endobariatrics. So in terms of lifestyle modification in IBD, gives patients about a 5 to 10% weight loss. And we know this from the general population. As I'm going to show you, there's very little data actually in our IBD patients. Lifestyle modifications really should be used in conjunction with another intervention if there's a need for clinically significant weight loss. And of course, it's always helpful to engage with an obesity dietitian when you're helping your patients. When we look at our studies on dietary modifications, there was a single study that looked at the Mediterranean diet to see if this led to weight loss in patients with IBD. And while the authors concluded that there was a significant decrease in BMI, a waist circumference, reduced liver steatosis, and improved quality of life, it's important to actually look and see that the BMI only dropped by about zero point 0.5 in both the UC and the Crohn's patients. So I would argue that while that is may have been statistically significant in the study, it's not clinically significant, and it took patients from a BMI of 25.5 to a BMI of 25, which I don't think it makes a significant difference. A few studies have been done looking at intermittent fasting, one during Ramadan. None really assessed weight loss per se, but interestingly, they showed that there was no change in the inflammatory markers. It did not worsen their disease. And then, most recently, from our colleagues at the University of Miami, Oriana Damas and her group showed that their intermittent, low calorie, plant based diet may actually enhance the response to induction therapy in those with active ulcerative colitis. In terms of exercise, unfortunately, none of these studies are actually assessing the impact of the exercise regimen on weight loss. But what they did show was that in various exercise regimens, there was no increase in their disease activity, and it was tolerated very well. One of the studies actually showed that in patients who had more exercise were less likely to develop active disease, but these studies were quite small, and so future research is certainly needed in this area. This is our handout that I use for the Mediterranean diet to talk about lifestyle modifications with our patients, and I've adapted this from the ECU scholarship program. The Mediterranean diet should include plentiful fruits and vegetables, whole grains, lean proteins such as turkey, fish, chicken, and limiting red meat to less than once a week. We encourage our patients who are not lactose intolerant to have a low fat dairy, and we do try to limit the sweetened beverages, candies, processed foods, etc. As we'll talk about later today in our talk on fiber, patients who have strictures, active disease may need texture modification, but it's not about restricting these foods. We'll talk about changing what they look like. In terms of exercise, the recommendation for the general population is about 150 minutes of moderate intensity aerobic exercise per week, plus strength training 2 to 3 times per week. And the strength training is really crucial here to prevent muscle loss. I've put some examples on the side for you here in terms of what to recommend for patients. In our IBD patients, a couple of pearls in terms of thinking about exercise. It's important to assess for sarcopenia prior to starting a weight loss program. You want to know where your patient's muscle health is before you start in terms of knowing what to recommend. I try to encourage a minimum of 30 minutes of walking daily. I have found that patients are much more apt to go and walk or to get out of their house and walk their dogs, go walk a little bit to work, as opposed to recommending they get on a treadmill and run, etc. This is a little bit more easily adaptable into their lifestyle. I always recommend resistance training 2 to 3 times per week, and this is especially if they're going to start on a pharmacotherapy where muscle loss is a known side effect. I very commonly use online exercise videos and programs. These are easy for our patients to access. They can do it whenever is convenient for them, and they have easy access to a bathroom. In your patient who's having diarrhea, incontinence, leakage from their J pouch, they're not apt to go to a park and run or go to the gym where they don't know where the bathrooms are. So this can be very helpful. There are lots of walking videos, resistance training videos you can share. We found that short bursts of exercise, called exercise snacks, are a good alternative for patients who are very fatigued. It can be very daunting to recommend a 30-minute exercise video or a 40-minute video for a patient, but if they do 5 minutes here and there throughout the day, sometimes this is much better tolerated. I always suggest you engage with a physical therapy team for guidance. And this is especially true in your patients who have joint pain or other exercise limitations. And in your patients who have been to the operating room recently, always talk with your surgeons about any exercise restrictions that the patient should have before recommending an exercise program. So let's move on to pharmacologic interventions. I'm sure what you've all been waiting for. So, we certainly have a lack of clinical trials supporting the efficacy and safety of pharmacologic treatments in obese patients with IBD. What you'll see on the right are the FDA approved weight loss drugs. And while we often talk about the GLPs, there are a few other drugs here. So, I think it's important to talk about them. These drugs have given about a weight loss of about 5 to 22% in the general population. We don't know what that percentage is in IBD patients. The contraindications, as you probably all well know, vary based on the different therapies. Many of them, and we'll talk about this, have GI side effects. In the last few years, there's no question that the major focus has been on our GLP and GIP agonists, and that's because we're getting the most significant weight loss, almost comparative to endobariatric and bariatric procedures. Other options, though, just to remember, if you're having trouble with insurance coverage or the patient isn't able to get these medications, there are other options. There are things like metformin, phentermine, Contrave, etc. And then always important to think about novel therapies that are on the horizon, that are coming up: leptin analogs, amylin analogs, and even an activin inhibitor, which will help reduce the muscle loss in our patients. So, GLP agonists and IBD, what do we know? There are four studies that I put here, basically none of which have shown really anything more than just safety and tolerability. That has been the big focus early on. And so we know in these studies that show that there were pretty minimal side effects compared to the general population. It was very similar to what the general population saw. Certainly no increase in disease activity, no worsening of the IBD. In fact, Priya Siegel's group actually showed that the GLPs may have been associated with a reduction in CRP and calpro from baseline in a small cohort of patients with Crohn's who were treated with these medications for weight loss. So the take home from these is that the drugs are likely safe and tolerated. And there's this question, this hope that potentially these drugs can be used also for therapeutic reasons. So what does that mean? Is there efficacy beyond weight loss for our patients who are starting on a GLP? I really like this diagram from our colleagues in Greece looking at the role of GLPs in IBD patients. And the interesting story is that prior to the rising popularity of these medications for weight loss, these novel peptides were actually studied in connection with IBD and systemic inflammation. We know that GLP-1 receptor expression and postprandial GLP-1 release are reduced in IBD patients with active disease. And there's anecdotal evidence suggesting that there's improvement both in the IBD symptoms, but most importantly, in bowel healing with GLP-1 use. There was an interesting study in a group of patients who were diabetic, about 4,000 IBD patients with diabetes, that had various treatments. And those that were treated with semaglutide had a significantly reduced need for oral steroids, reduced need for biologic induction, and a reduced rates of IBD hospitalizations and surgeries as compared to other anti-obesity and diabetes medications. And so therefore, this is also signaling that the GLPs may be playing an additional role. A few murine models have demonstrated that GLP-1 significantly reduces these pro-inflammatory cytokines and mediators with reduced intestinal damage and dysbiosis. So all of this is very encouraging to show that these drugs are not only safe, but potentially actually beneficial not only for weight loss and diabetes management, but also for the underlying IBD. A few pearls that think about when I'm starting a GLP in our IBD patients. One is you're always going to ask about a history of thyroid cancer, both personal and family. As you probably well know, GLP-1 use is contraindicated in those with a history of medullary thyroid cancer or MEN2. I ask our patients about a history of pancreatitis. It's not that uncommon in our IBD patients. It's important to ask. And I generally avoid use if possible in that population, given the increased risk. In women, I ask about plans for pregnancy. Remember, we're treating an otherwise healthy, generally young patient population, and you don't want to start these medications and then have a patient tell you that they're interested in getting pregnant in 2 or 3 months. So you want to know about that up front. These drugs are not approved for use during pregnancy. You want to discuss the common GI and other side effects. I always bring up constipation because patients want to know. For some of our patients, they'd love to go from 8 or 10 bowel movements a day to something less. And so, therefore, that's a wanted side effect. But some of our patients struggle with constipation. So, it's important to bring that up beforehand. I always encourage our patients to be seen by an obesity trained dietitian to discuss eating strategies. Once patients start these meds, it can be hard to eat. They lose that drive, that passion for food. They lose that interest, and food just doesn't sound appealing. You want to have somebody be who can encourage small, frequent meals, prioritizing protein, all of these things. And it's incredibly important to reduce bias in this community and have a dietitian who's well trained to take care of obesity patients. You want to check baseline biomarkers and/or an intestinal ultrasound to assess disease activity. Why do I suggest this? I suggest this because it's important to know where our patients are starting. Because if they call you in a month with diarrhea, abdominal pain, nausea, vomiting, it's important to know whether this is their disease activity or whether it's the drug. And so we need to know where they're starting in order to do this. It is not a contraindication to start this medication in a patient who's actively flaring, but you just want to know where you're starting. So if you need to recheck these levels during the course, you can do so. In patients who have had biliary colic, I definitely consider a pretreatment ultrasound to assess for stones. If there's been any question about biliary disease or right upper quadrant pain, this is certainly an increased risk on these medications. And so I like to know, and it's a helpful for a risk benefit conversation with the patient. In our practice, we obtain a baseline fiber scan in all of these patients starting on medications who have abnormal LFTs, and as well for research and some who do not. It's important to know also just for that risk benefit conversation with the patient to be able to share with them and then track that fiber scan so that you can see improvement in their fatty liver and steatosis. And then finally, I always talk about the need to stop these medications prior to endoscopic interventions. You don't want this to be a surprise for patients, but I'm sure all of your practices are slightly different in terms of the anesthesia recommendations. But it's important to bring this up. If you have a patient who's getting a colonoscopy in 2 weeks, today's not the day to start these medications because they're going to need to stop them. And so it's just important to bring up. What about other medications? Is it all about GLPs? Absolutely not. There are other anti obesity medications on the market, very minimally studied in IBD, unfortunately. There's one retrospective study of about 36 patients who are on anti-obesity meds, and I showed you the list here, including Contrave, phentermine, and other meds. And the study really showed that there were no adverse events compared to the general population, and these patients were actually IBD and non-IBD matched controls in this study. And so the two groups had similar weight loss, no change in the adverse events, and there was no worsening in the IBD in any of these medications. While there are no studies specifically looking at weight loss in metformin, there are two studies showing potentially improved disease activity, similar to that for the GLPs. There was a murine model that showed that metformin decreased activation of pro-inflammatory markers such as TNF and reduced oxygen species in cell models. And there was a study in patients with IBD and diabetes where they showed that metformin use actually decreased the need for IV steroids after 2 and 3 years of use, with a lower risk of needing an IBD-related surgery. So this has the potential to also be beneficial for the disease course. I bring up orlistat just to say that while there are no studies assessing weight loss in IBD using this medication, given the side effect profile, it's not something I recommend for our patients. So lastly, just very briefly, I wanted to bring up endobariatric procedures. I think this is often overlooked in our IBD patients. However, in those who do not have foregut or upper GI Crohn's disease, this is certainly an option for our patients and should not be overlooked. There's limited data on safety and efficacy of these procedures. However, there is a retrospective study looking at 7 patients. 3 had an intragastric balloon, 4 had an ESG. All of them had successful weight loss, and there were zero adverse events that were associated with the endobariatric procedure. We certainly need more research into this area to show about safety, tolerability, and efficacy, but I want you to consider this in a patient who maybe hasn't had effective weight loss on a pharmacologic therapy, wasn't able to tolerate a pharmacologic therapy. It's a nice option if the patient is not interested in going to a bariatric surgery, but is still looking for something else to help with their weight loss. So, in conclusion, the prevalence of obesity is certainly rising across the United States and within the IBD population. Obesity and specifically visceral fat is associated with worsened IBD outcomes. So this is not about cosmetics. It's not about patients, wanting to be thinner. This is about helping our patients to have better outcomes from their disease standpoint. Lifestyle modifications such as dietary changes and exercise should be part of any weight management program, but remember they're often not sufficient for clinically significant weight loss. Early studies show no significant safety concerns for the use of GLPs and other of these anti-obesity medications. We need to be screening our patients for contraindications, assessing their disease activity before starting, and making sure to have these conversations about risks and benefits with the patients. There's unfortunately limited data for other anti-obesity medications, but we're looking towards the future, and I know a lot of groups are working on this. And remember that endobariatric interventions can offer a non-invasive strategy for weight loss in patients with IBD, but we need future research to know where this is going. And with that, I'd like to thank you so much, and I'm happy to take any questions. Please feel free to unmute if you'd like to ask anything. There was a question about sharing presentations. This whole talk will be recorded, and so therefore that will be distributed. Of course. Any questions from the group? All right. If there are no questions, then we will get started with our next talk, just in the interest of time. I would like to go ahead and introduce Rose Lipner. She's one of our fantastic dietitians here at Mount Sinai and head of the Nutrition and IBD inpatient program. She's going to speak to us today about nutritional care in our post-operative Crohn's disease patients. Welcome, Rose, and thank you so much.
Thank you, Steph. I'm going to go ahead and share my screen. Can you hear me okay?
We can. It's perfect.
Perfect. All right. So hi, everyone. Good morning. My name is Rose. As Steph mentioned, I'm one of the clinical dietitians at Mount Sinai and one of the IBD dietitians at Mount Sinai as well. And today I'm going to be speaking about the nutritional care for the post-op Crohn's disease patient and how we can really help transition our patients from the perioperative diet to a more Mediterranean style diet. So here's the outline of what I will be discussing today in this presentation. So, understanding the nutritional management following IBD surgery is incredibly relevant because around 80% of patients with Crohn's disease will require surgery within their lifetime. So, following surgery, many patients are afraid to advance their diet because they're worried about experiencing symptoms or obstructing on certain foods. And sometimes there can unfortunately be really little guidance for patients on how they can safely return to a regular, more normal diet. And while some restriction is necessary post op, as I'll be mentioning in this talk, unnecessarily restrictive behaviors following surgery can be really dangerous for our patients because they can lead to a number of nutritional complications. So, some of these complications include micronutrient deficiencies, such as low iron or low B12, unintentional weight loss due to lack of caloric intake, ARFID, or avoidant restrictive food intake disorder, which you guys will be learning more about in one of the awesome presentations that we have coming up. So ARFID is where patients may never really reintroduce those foods that they associate with needing a bowel resection, or they can just have severe anxiety related to eating those foods that may have caused them symptoms in the past. And because of these consequences, malnutrition and IBD can be quite common. And the reported prevalence is between 20 to 85% of patients. And this wide range is really due to the large amount of variability among the studies that we have. And research has actually shown that around 70% of those with IBD who are malnourished are inpatients, and the patients who are more likely to be malnourished have Crohn's disease. So, this is why optimizing nutrition throughout the surgical period is really so important because we know that malnutrition leads to longer hospital stays, more non elective surgeries, and overall a higher risk of mortality. So it's really, really important that we're educating and empowering our patients to avoid any excessive or unnecessary restriction following surgery so that we can avoid any of these nutritional related complications. So, when we talk about Crohn's disease surgery, it really starts before the OR. Preoperative nutrition is truly our moment to help improve the surgical outcomes of patients. And it's helpful to think about going into the operating room like sort of running a marathon. Just like you would never show up for a marathon unprepared or untrained, you shouldn't be showing up for a surgery unprepared. So, for non emergent or elective OR cases, we really want to try to optimize our patients nutritionally. So, to do this, we want to identify and treat malnutrition by optimizing caloric and protein provision and also addressing any micronutrient deficiencies. We should also be encouraging our patients, if it's allowed and they're cleared by surgery, to exercise by using weight bearing exercises and aerobic exercises like swimming and running. And we should also be offering our patients immunonutrition shakes, which contain protein, arginine, and omega 3s, and have been shown to be effective in reducing post op stress and complications. So, this should be given 5 days before surgery, twice daily. And then we also have some research to suggest that carb loading immediately before surgery with apple or white grape juice can really help reduce surgical stress on patients during the operation and post-operatively. And this can be done around 3 hours before surgery, but should always be discussed with the medical and anesthesiologist team. And lastly, it's really beneficial to send patients a shopping list before surgery so that they can really prepare and have things in the house ready to go and set up for them to make their transition back home a little bit smoother. So, in the hospital, patients are started on clear liquids and then they're advanced to solid foods. It's really, really important that we're not keeping patients NPO or clear liquids for prolonged periods of time because these diets, or lack of diets, I should say, are extremely low in calories and protein and can lead to unintentional weight loss and therefore exacerbate any already existing malnutrition. So once transitioned to solid foods, patients should be on a softer texture diet or diets that are lower in insoluble fiber due to the anastomotic swelling or the new ostomy site. And we can also continue to consider the continuation of immunonutrition shakes, which may be beneficial in this post-operative period or have been shown to be beneficial in this period. And then we also have some research to suggest that caffeine post-operatively can actually shorten the length of return of bowel function time and overall decrease the length of stay in the hospital. So coffee might be something interesting to consider providing to patients post-op in the PACU. So before patients go home, they're hopefully seen by a dietitian to discuss the diet that they should be following once they're discharged. So typically, we're instructing them to follow a softer or lower in insoluble fiber diet. And we always emphasize that this is temporary and should only be followed for a few weeks post surgery. So, what does this softer texture diet mean? We mainly want patients to limit raw fruits and raw vegetables, nuts and seeds in their whole forms, and instead encouraging our patients to consume things like applesauce, smoothies, pureed soups, and nut butters, things that are a lot softer and smoother to get down. Something else that we typically advise our patients to do is consume smaller, more frequent meals. which may be better tolerated than those three large meals that we might be used to. And as they're recovering at home, it's often helpful if patients have oral nutrition supplements like Ensure or Keep Farms on hand in case they're not feeling up for eating a full meal or their nutritional intake is inadequate or lower than normal. And lastly, we want to be monitoring for any diarrhea or any fluid losses post surgery and encourage the use of oral rehydration solutions if there is increased diarrhea or output. So, around 1 month post op is when we want patients to start to reintroduce more variety back into the diet. So, instead of pureeing vegetables, patients can peel and cook their vegetables until they're fork tender. Instead of putting fruit in a smoothie, patients can peel fruit or have very ripe fruit instead. And we want to continue to encourage our patients to chew food very thoroughly until it's at a softer consistency. We want to continue to be monitoring our patients' weights and ensuring that our patients are gaining or at least maintaining their weight and not losing any weight. And lastly, pending surgical clearance, we can encourage some light exercise such as walking or lifting very light weights just to maintain the muscle mass. At around 3 months post op, our goal is to have patients be following a Mediterranean style diet, which studies have shown to be effective in minimizing inflammation in our IBD patients. So, as Dr. Gould mentioned, the Mediterranean style diet emphasizes a lot of fruits and vegetables, unsaturated fats like olive oil and avocados, legumes and whole grains, and then limiting red meat and processed meat and also processed foods to ideally less than once a week. And overall, at this point, we want to continue to monitor for signs of malnutrition and any micronutrient deficiencies, and also be monitoring for any signs of obstructive symptoms as well. So, this is an example diet transition from the perioperative period all the way to the 3 month post op mark. So at the top, we're starting with pureed and very soft textures, and then we're going to cooked and peeled fruits and vegetables to ultimately incorporating those harder textures and following that Mediterranean style diet. That's the overall transition and diet progression that we're working towards with our patients. And on the right hand side of the screen are some helpful images to really visualize this diet transition. So, for example, if you look at the second row where it says carrots, you can see that perioperatively, a patient may consume pureed carrot soup, then a month after surgery, have fork tender peeled carrots, and then eventually transition to raw whole carrots. And even though the goal at this 3 month mark is to limit any sort of restriction that patients may have, there are some special considerations for patients with an ostomy, a J pouch, short bowel syndrome, or for patients going through an active IBD flare. So these patients may require more lifelong restrictions than the typical IBD patient. So some of these special considerations include people with ostomies and with short bowel syndrome. And they, as I just mentioned, may benefit from long-term texture modification to reduce their risk of obstruction. So even past that 3 month mark, we want these patients to continue to avoid those really hard raw fruits and vegetables, like avoiding a large salad or a bunch of kale. It's also important that these patients are monitoring their stool and urine output and utilizing oral rehydration solutions as needed. And some good oral rehydration solutions that we typically recommend include drip drop and liquid IV. And then other strategies to minimize symptoms or complications post surgery include limiting simple sugars like sodas, juices, and candies, understanding foods that may cause odor or discomfort, reviewing anti-diarrheal regimens with the patient and their team, emphasizing those smaller and more frequent meals instead of those three large meals, and providing a daily chewable multivitamin can be really beneficial for patients to just address all of their needs and ensure that they're getting an adequate amount of vitamins and minerals through the multivitamin. And lastly, I wanted to touch upon patients who can't adequately meet their caloric needs through PO intake alone. The team may want to consider supplemental TPN or IV hydration if it is indicated. Here are my references, and thank you guys. And I'm happy to take any questions that you guys might have.
Thank you so much, Rose. That was a fantastic talk. There are two questions in the chat, and then I have a couple of questions for you as well. The first
Great.
question asks, can you explain how these key ingredients in the immunonutrition shakes actually help our patients? And how do you explain this to patients when you're seeing them? And I'm happy to jump in as well.
Sure. Yeah. So the immunonutrition shakes have certain nutrients that are going to help with wound healing, tissue repair. The shakes also provide a really good amount of calories and protein as well, which can help with the caloric provision for our patients. And the shakes have also been shown to reduce like infection risk post-op too. Dr. Gold, I don't know if you have anything else to add.
Yeah, absolutely. And I love using the reference that Rose already told you, which is this concept of a marathon. I tell patients that going to the operating room is like running a marathon. And would they ever show up to a marathon unprepared? And they always laugh and look at you and say, no, obviously not. And then you say, great, well, then it can't send you to the operating room unprepared. I tell our patients that these shakes will help boost their immune system to help with healing postoperatively. As you said, they have good calories, they have good protein. And then I explain that the glucose load the night before is that, you wouldn't go into a marathon or anything having not eaten. You need glucose, you need that drive to be able to fight, and that prevents metabolic shifts on the operating room table that can help them heal faster, get out of the hospital faster. And usually patients are pretty amenable to that. There's another question in the chat here that says, do you use different transitions like earlier vegetables after colonic surgery compared to small bowel surgery? Is it a smaller caliber anastomosis or adhesions? So do you treat your patients differently who have small bowel resections versus colonic?
Yeah, so definitely with small bowel resections, we want patients to, definitely still be avoiding those, rougher textures, and in both of these surgeries as well. I don't know, Dr. Gold, if you want to jump in as well as to what you typically recommend for those patients too.
Absolutely. Yeah, I think a lot of this, even if you think about a colostomy versus an ileostomy, it's really
Hmm.
those colonic surgeries, I think you have to be less concerned about textures. And as you said, the anastomoses tend to be less narrow and therefore there's less concern about swelling, et cetera, and they tend to not
Right.
obstruct easily. And so
Yeah.
I still in that acute 2 week period, as you said, I still love to kind of keep those textures nice and soft for our patients. But nonetheless, I do think that you can treat them a bit differently in the small bowel resections, should really be watching those textures carefully.
Yeah, and also like hydration is really important in those small bowel surgeries as well, as opposed to someone who has a colostomy. With an ileostomy, we want to make sure that they're staying really well hydrated and they're not, having excess amounts of output or fluid losses too.
Absolutely, that's a great point. One of the questions I had for you is that the introduction of fruits and veggies can be so challenging for our patients. Are there fruits and vegetables that you tend to start with that are easiest tolerated?
Yeah, that's a really good question. I see a lot of patients who are really afraid to reintroduce fruits and vegetables, especially. I found that the best veggies to start with would be those like starchier vegetables, things like potatoes, carrots, squash. Those are going to be really easy to, start off in their pureed form. So you could do like mashed potatoes or like a pureed soup, and then can be really easily cooked very well. And then ultimately going into their more raw form or with the skins on them. That's a really good transition. And then in terms of fruits, bananas have been pretty good throughout those three stages. They're pretty well tolerated and they're easy to turn into like a high calorie snack if needed to. And then we could do something like an apple. So, like starting off with applesauce, then doing a peeled or like a cooked apple for dessert. And then eventually, like having a raw apple would be the goal.
Absolutely. And the last question I had for you is that I think we've all been on IBD service and taking care of these patients in the hospital. And it's so hard because every time we turn around their NPO, they have a procedure, they have an MRI, they have an endoscopy coming up. Is there anything that we can do as gastroenterologists and dietitians to try to limit the NPO status? Is there something we do, something special here at Sinai, et cetera, that you're able to do to keep them eating while they're hospitalized to keep their nutrition up?
Yeah, yeah, totally. I think that the most important thing here is communication. So having clear communication between team members is really key to limiting NPO or clear liquid time. And that's why the multidisciplinary team at Mount Sinai, the IBD team, with the dietitians and the doctors is really important because the dietitians can sort of help remind the doctors of how long a patient has been NPO because that can be really easy to lose track of among everything else going on. So it's really important to have that dietitian on the team just to, remind doctors and keep doctors and the whole team updated as to a patient's nutritional status.
Absolutely. Thank you so much. Great answers.
Thank
Are
you.
there any other questions from the group? Feel free to unmute or put in the chat. All right. If there are no other questions, then I am going to get started with the next talk. I'd love to take the next 15 to 20 minutes and talk to everyone a little bit about fiber, which is such a hot topic in IBD. And we'll talk a little bit about the swinging pendulum of fiber recommendations, where we've been, where we are now, and where I think we're going in the future. So I look at fiber introduction and I think of this slide. So in the last decade, we were recommending these low fiber, very kind of soft texture diets for all of our patients with IBD. And I'll tell you a little bit about where these recommendations came from. But the diets looked like this, kind of pale and white color, Cheerios, toast, tea, chicken, bananas, pancakes. And yet somehow we have gotten to a point where we are recommending this diet with plentiful fruits and vegetables. But unfortunately, this feels like it may be hard to get to for our patients. And I'm going to talk to you a little bit about how to get there. So when I give this talk, I always like to talk about what is fiber because I think it's an important concept here. So fiber is essentially just a carbohydrate polymer. It has 10 or more monomer units, but the key is that they're not hydrolyzed by endogenous enzymes in the human intestine. So that means that they don't get broken down by the gastric acid when they're in the stomach. They somehow escape digestion in the small bowel, and then they make it to the colon to undergo anaerobic fermentation by the microbiome. That is the key. They have to make it to the colon. And fiber is commonly divided into two subtypes you'll hear, soluble and insoluble. And yet what you're going to learn today is that I think it's far more complex than soluble and insoluble, and we should be taking into account the viscosity of these fibers, their ability to be fermented. Can they hold on to water? On the right here, you'll see some examples of common dietary fibers in this more traditional soluble-insoluble breakdown. And you'll see the examples of the food sources here, including soluble fibers such as your oats, nuts, seeds, psyllium husk, flax, where your insolubles are your broccoli, wheat bran, nuts, and seeds. When I think of an apple, that's the way I use this to describe to patients. We talk about the insoluble fiber being in the peel and then the soluble being in the flesh of that fruit. So low fiber diets, these were previously recommended for all patients with IBD and not just those with strictures or ileostomies. And the thought was that if we gave patients less fiber, they would have less stool bulk and therefore they would have fewer symptoms. And yet, there were large epidemiologic studies that showed that patients with IBD, and specifically those with Crohn's, eat significantly less fiber compared to the general population. And this is probably secondary to these recommendations. There's not a clinic that goes by that I don't have a patient that says, but I was told not to eat any fiber. Low fiber diets are commonly recommended after bowel surgery. And then, unfortunately, as Rose so nicely pointed out, you need that nice transition back to a regular diet, and they're not making those transitions. We here at Sinai really like to focus on soft textures, not low fiber, and then a transition to a harder texture diet. What's interesting is that so many of our dietary therapies in IBD, such as exclusive enteral nutrition, are often low or have no fiber. And so some of the arguments for low fiber diets have said, well, if that's functional, if that's efficacious, then we shouldn't be giving our patients fiber. But the reality is that these diets are probably affecting microbiome changes and other immunologic changes and not related to changes in stool bulk. There's very little evidence to show that a low fiber diet improves symptoms in patients with IBD. When you actually look, they're not having less diarrhea, less belly pain, etc. There was a randomized controlled study that showed that low fiber compared low fiber to non restricted diet in patients with active Crohn's disease. And there was no difference in their Crohn's activity or their symptoms between the two groups. And yet, despite all of this, low fiber diets are consistently being recommended at many practices and academic institutions across the US and abroad. So I think you're starting to see the pendulum swing, but it hasn't fully swung yet. Why shouldn't we use a low fiber diet? So, long term diets that are low in fruits and vegetables are certainly associated with micronutrient deficiencies and malnutrition. We see tons of patients in our clinic who have been on a low fiber diet since a surgery 10 years ago, and they're not eating any fruits and vegetables, and they have a vitamin C level that's undetectable. There were two studies in IBD identifying numerous patients with clinical scurvy, and the common theme amongst all of those patients were low or no fruit and vegetable intake. We know that low fiber diets usually are higher in refined grains and sugars and processed as well as ultra processed foods. You think about the emulsifiers and thickeners. And we know in ultra processed foods in IBD, there are numerous studies that show that these have a poor impact on the gut microbiome, intestinal permeability, and luminal inflammation. These low fiber diets are generally cause higher rates of diverticular disease. There's constipation, anal fissures outside of the IBD, but our patients can certainly get these as well. And we know that the fiber in the diet is associated with general cardiometabolic health, reduced rates of GI malignancy, et cetera. So we want to be providing fiber to our patients. What other benefits of there are fiber in IBD? Well, specifically for our IBD patients, we've shown that dietary fiber modulates the composition of the microbiome. Patients who eat more fiber have enrichment in their bifidobacter, their lactobacillus, and it's these bacteria that produce short-chain fatty acids like butyrate that are anti-inflammatory. We know that dietary fiber can actually restore the mucus layer in the gut, which is that barrier between the microbes and the host immune cells. In ulcerative colitis biopsy, studies have shown barrier defects, and therefore, in these patients on low fiber diets, they generally have these bacteria that support mucin degradation, which is harmful. And dietary fiber has also shown to modulate the tight junctions, goblet cell activation, regulate epithelial cell growth, and even direct cytokine and chemokine secretion. So, not only is a low fiber diet bad for our patients, but a high fiber diet has been shown to be beneficial. Other studies that have been looked at IBD and benefits of fiber and IBD have really shown that the introduction of fiber is beneficial for the quality of life for our patients, leads to a reduced CRP, certainly less dysbiosis, and one of the studies even showed increased rates of clinical remission that were maintained at 2 years simply with changes in dietary fiber. So, when you think about fiber recommendations, I think it's really nice to look at the guidelines to see that this paradigm shift has been happening. If you look at the 2020 ESPN nutrition guidelines, this was the first time you started to see this shift in the recommendations that were previously about a low fiber diet. And the 2020 guidelines stated that took out the word low fiber and instead used the term adapted texture. Then in 2023, the British Nutrition and IBD guidelines came out and said that there was no need to restrict fiber intake in those with quiescent and stable IBD. And this was a big shift for us. This was not previously recommended. That same year, the ESPN updated their guidelines with a much more in depth discussion about the benefits of fiber in IBD. They suggested avoiding fiber in those with stricturing Crohn's, and they said that this was a logical approach, but that there was no evidence to actually support it. And again, recommended this concept of adapted consistencies instead of low fiber. Most recently, the 2024 AGA practice update came out and said that whenever possible, patients should be reintroducing fresh fruits, vegetables, and fiber, preferably soluble fibers. And they also said in those patients who were previously restricting fiber, that successful reintroduction of fruits and vegetables can be achieved with careful chewing, cooking, and processing of these foods to achieve favorable, soft textures to allow safe ingestion of fiber. So you've clearly seen this transition from low fiber to adapted textures in that we currently recommend. So I think many of you may be asking yourself, how do we get our patient who's eating this to be eating this? And it's very challenging. And many of your IBD patients are going to tell you that there's no way they can do this. And I tell patients that if Cookie Monster can do it, so can they. So, how do we do this for our patients? So, texture modification 101. If you take anything from this talk today, just take home that the smoother, the better. So when we have our patients, we ask them to peel and cook all of these vegetables. If they're still having symptoms or they're still anxious about this, we sometimes have them put those vegetables into a blender and make a pureed soup. Broccoli cheddar, pureed cauliflower, carrot, butternut squash. So many options, and we provide our patients with handouts on this. We tell our patients to peel all of their fruit, and the fruit should be ripe and soft, to have them avoid dried fruit. And you all know about what those cantaloupes and honeydews in December taste like, those crunchy melons. You really want them to avoid those and have nice, soft textures. We have patients avoid whole nuts and instead use smooth nut butters. I have them avoid whole, fresh, and frozen corn kernels. Those can be hard to digest, but instead have corn flour, corn tortillas, polenta, grits, corn bread. We do have patients avoid popcorn and large seeds if possible. And then if they're having lentils and beans, I either have them mash them or puree them down into their soup. And especially if they're having active symptoms, I have them avoid hard greens such as kale unless it's pureed or put into a smoothie. Does everyone with IBD need texture modification? Absolutely not. This is not for everybody. This should be for your patients who have active IBD, the patients who are having a lot of GI symptoms, abdominal pain, diarrhea, rectal bleeding. I explain to our patients this isn't going to reduce inflammation. This is going to help their symptoms so that they feel better. This is not about disease control. This is all about symptom management. In our patients with an ileostomy and a jejunostomy, this is about mechanical changes to the food so that they prevent obstruction. So when they're having GI symptoms, it's about symptom reduction. In our ileostomies and stricturing patients, this is about prevention of obstruction. So in anyone with an ileostomy or jejunostomy, I recommend texture modification. In those patients, even if they have quiescent Crohn's, but they have a known fibrotic stricture, pretty careful about textures. And any patient who's had a history of a small bowel obstruction. Some of our patients with a J pouch need texture modification, and you're going to hear more about this today, but others do not. So what does texture modification look like? This is from one of the handouts that I've created for our clinic. I think it's really important to show patients with pictures what this looks like and not just with words. It's about having applesauce over an apple, as Rose carefully pointed out earlier, about having oatmeal instead of granola. If they are going to have beef, we generally recommend ground beef over a steak. We usually recommend soft breads instead of bagels or breads with lots of nuts and seeds, making smoothies, creamy hummus, creamy peanut butter. You can also cook spinach and other vegetables into a frittata, bake berries into a muffin, etc. A lot of patients and doctors say, but that takes a lot of work, a lot of meal prep, and I don't have the time to do this. So I just wanted to show you that there are a lot of products on the market that can really help your patients texture modify without having to be blending and spending hours in the house. These are pre-made blended soups that are really great for patients. They can add to them, but it's a nice base. We tell patients to get things like peeled and roasted bell peppers, no sugar added applesauce, creamy peanut butter, smooth hummus. Lots of places now make these fruit and vegetable pouches and yogurt pouches. These are great for our patients, and we encourage that, as well as things like pureed pineapple and other brands. So lots of options so that your patient doesn't have to be in the kitchen cooking 24/7. Can you use fiber to reduce GI symptoms? So this is a really interesting question. This becomes not just about the actual disease, but can we make them feel better? When you're trying to decide on the type and how much fiber to recommend, I think it's important to consider the type of fibers and the textures. Do we need solubles, insoluble? Do you want viscous or fermentable? Does the patient have active inflammation? In our patients who present with constipation or incomplete evacuation of their pouch, we often are adding insoluble fiber, assuming there's no obstruction. That's things from like nuts and seeds, whole wheat products like whole wheat breads, brown rice, berries. Remember, I talked about that skin on the apple and wheat bran. And this can also come from a product like Citracel, which is methyl cellulose. If your patient's coming in with diarrhea, watery output, or incontinence, you want to avoid the insoluble fibers and add soluble fibers to help bulk stool. And I think it's so fascinating that a single concept like fiber can actually help both diarrhea and constipation. Just shows the power of this compound. So in your patients with diarrhea, you want the soluble fibers. That's going to be things like avocado, peeled potatoes, sweet potatoes, oatmeal, and the flesh of various produce. You can also consider supplementing with psyllium husk. If you have patients coming in with a lot of bloating and abdominal pain, we try to remove those highly fermentable fibers. I've also found that patients who mix their fiber with a carbohydrate source tend to tolerate it better, so having it with a rice or a pasta. And we avoid the soluble fermentable fibers such as beans, nuts, seeds, and inulin. And I'll point out that inulin is in a lot of pre-made protein shakes, so it's something that patients should be looking for if they're having a lot of bloating or abdominal pain. So, will the pendulum swing back? My answer is yes and no. I think we should and will continue to avoid these broad recommendations to restrict all fiber, especially fruits and vegetables. I don't think we're going to go back to a place where we say that all patients with IBD should be restricting fruits and veggies. However, I do think we will approach more precision nutrition, in which we identify which patients would benefit from which specific fibers and at what point in their disease course. There must be times in the disease course when patients benefit from a specific fiber versus a time when it can actually worsen their disease course. So it's not that everybody should be eating fiber at all points, but when should we be recommending fiber and which fibers to which patients? And how does their microbiome impact this? Are they able to ferment those fibers at different points in their disease course? I think this is very well demonstrated by the beautiful work done by Heather Armstrong's group looking at unfermented beta fructan fibers, where she showed that these fibers that are generally beneficial in IBD can actually have a deleterious effect in patients with active inflammation who are not able to ferment them, worsening their inflammation. What we need to do is figure out how do we identify these patients so that we can provide them with that dietary guidance going forward. So, in conclusion, low fiber diets do not improve IBD activity or disease symptoms and are associated with malnutrition and micronutrient deficiencies. We know that dietary fiber reduces inflammation through changes in the microbiome, protection of that mucus layer overlaying the epithelial cells in the GI tract, and even immunocytokine signaling. For those patients with active IBD, a history of a bowel obstruction, those patients with a known fibrotic stricture and ileostomy, jejunostomy, we recommend texture modification over restriction. And again, if you take anything home today, the smoother the better. Peel, cook, and puree. And looking forward, we really need to identify which of those patients specifically benefit from dietary fibers, which fibers are beneficial, and when during their disease course should we be recommending them. So with that, I thank you, and I'm happy to take any questions. Any questions? All right. If there are no questions, I think we will go ahead and, in the interest of time, go ahead with the next talk. So we are so excited to welcome Dr. Professor Ben Horan to our panel of speakers to talk to us about nutraceuticals and specifically his experience with CUR-QD. Professor Ben Horan is the chief of gastroenterology department at Sheba Medical Center, Israel. He received his medical and gastroenterology training in Israel and was a postdoc scientist in immunology at Columbia University Presbyterian here in New York. Professor Ben Horan specializes in inflammatory bowel disease, and his main research focus is biological drug mechanisms and monitoring of IBD. He's published over 250 peer-reviewed scientific papers and has previously served as a member of the scientific community of the European Crohn's and Colitis Organization, ECHO, and as the chair of the Israeli IBD Society. At the present time, Dr. Ben Horan is a member of the editorial board of the Journals of Gut, APT, and JCC, and a member of IOIBD, and is frequently invited distinguished speaker at multiple international meetings. He's been the co-founder of 2 startup companies that I'm sure we'll hear a little bit about today, and is also the director of IBD Passport, a web-based global non-for-profit support program for traveling IBD patients. So welcome, Dr. Ben Horan. We're so excited to have you join us this morning.
Thank you, Stephanie, and I much appreciate the invitation. This has been my first time hearing this webinar nutritional program, and it's just been fantastic. I actually had quite a lot of questions to your previous talk about tahini and stuff that we use here, but
Sure.
in the interest of time, maybe we'll leave it to the end of the Q&As. Anyway, so it's a pleasure to talk to you, albeit from a little bit afar. So I will start my share. Can you see my screen?
It's perfect, yes.
Yeah. Okay, so my task was here indeed to try to talk about a different angle of how we treat diet in IBD, and that is a part of nutraceuticals, which I hope by the end of this short talk, I'll try to convince you that dietitians and healthcare professionals that are dealing with diet in IBD should also take nutraceuticals as part of this comprehensive strategy combining pharmaceuticals with dietary intervention and nutraceuticals. I have disclosures which unfortunately are quite long, but I specifically outline a relevant disclosure that Heavy Nature is a spin-off company of Shiba that I have some options in, etc., and involved with, and this pertains to the topic ahead. So delving into what are nutraceuticals, basically they are part of what we call integrative medicine. And integrative medicine is a broad term that incorporates elements of complementary or traditional or alternative medicine, sort of these alternating terms, into this comprehensive treatment plan alongside orthodox methods. And in that sense, I think the dietary topics that we have touched upon in this webinar are all incorporated within this comprehensive strategy as well. Now, I think it's interesting to note that when we think about this traditional Chinese or Indian or any other ethnic ethno-dietary intervention that have been around for 2,000, 3,000 years, we often have some skepticism about them, and rightfully so. But within that, I think it's also important to note that some of those herbal traditional medicines have found themselves heralded into the conventional medicine. And I'm just showing you 3 examples of herbal compounds that started as such, and then were developed further into conventional medicines. One of them actually awarding Toyo, the first women Chinese scientist to win the Nobel Prize for artemisinin, a malaria drug that started from a herbal compound used in traditional Chinese medicine as an anti-fever herb. So probably a lot of those around during the years were malaria and not fever per se, and that's how it evolved. Now, where are we in IBD? And I think it's not new to this audience that we have excellent pharmaceuticals, and the biologic era in the last 2 decades have really revolutionized our treatment, and the small molecules have recently done the same. But still, we are facing this therapeutic ceiling with about 30% give and take of complete remission in the clinical trials of our best medication. And this therapeutic ceiling is still a challenge. I think our patients are cognizant of that, and on top of that, many patients are interested in this integrative, alternative, complementary medicine. And this is shown by multiple surveys from North America and elsewhere, showing that anywhere between 50 to 80% of our patients actually use integrative or complementary medicines, often without us knowing that. So this is, I think, is something that is worth noting for us as HCPs. It's also of note that diet and integrative medicine, again, very much relevant to the webinar that we are now in, are among the most sought topics that patients are looking for on social media. Again, I think indicating the interest that we need to address. Now, in a recent, really nice, elegant review from the group at Leuven by Séverine Vermeer, they looked at these holistic or comprehensive integrative treatments. And I'm just saying there are a lot of them. We will not talk about all these integrative approaches. Some of them encompass mind, body, psychological interventions. Some are related to exercise, and some are dietary intervention or strategies per se that are the main topic of this webinar. But as you can see in the oval-shaped emphasize, so herbal products, traditional herbal products, occupy quite a lot of these potential strategies, with a coloring of those bars, as according to the review from Leuven, suggesting the level of evidence for them. So I think there is a lot of them, and we will not be able to touch on all of them, but we'll just start with one that actually got some attention recently. And honestly, it's not exactly a nutraceutical, it's more like a dietary component, but I think it exemplifies nicely how we should start to look at some of those. And this was a randomized controlled trial from a group in India with 80 patients with mild, moderate UC that were randomized in this double-blind placebo-controlled trial to receive a concentrate of coconut water compared to a sham, I would say, or a placebo water. Now, that's part of the problem of many of those randomized trials, because it's very hard to disguise to the patient the flavor of coconut. Investigators took the extent of trying to do it, and it's hard to really say how much is it disguised. But anyway, as you can see, the results overall were very interesting for showing clinical response and remission to be significantly better with coconut water, as well as endoscopic, as well as calprotectin response. But endoscopic response and remission were not better with the intervention. So still some question marks about this. There was a shift in microbial composition in the patient receiving coconut water. This may be like any dietary intervention that we do that may shift our microbiome as we know it, but may be related to some of the effects seen. But as Stephanie mentioned, we will try to focus this talk on one particular herbal remedy or herbal compound, namely curcumin and qingdai combination. Qingdai is actually, we shorten it for QD, and it's an indigo plant that was first published by a Japanese group back in 2018. And what they have done is taking this popular Chinese-Japanese medical herbal compound and test it in ulcerative colitis after seeing anecdotal reports of its efficacy. And as you can see, this compound is actually shown to be effective in a dose-finding study in a placebo-controlled trial compared to the placebo, both in clinical response and remission as well as in inducing mucosal healing. The problem with indigo plants and the QD plants are that are not completely innocent. So as with the robust efficacy as shown in the clinical trial of moderately severe, not only mild, moderate you see, but also moderately severe patient, also comes some cautionary notes. About 5% of patients will develop a mild elevation of liver enzymes. Usually they go away when you continue qingdai or half the dose, and there is no report of any irreversible liver damage ever. There are transient headaches that can occur in the first couple of days of treatment. We are not sure what the mechanism for that is, but usually they go away with continuation of therapy. A much more serious adverse event that is possible is pulmonary arterial hypertension. So this is a much more serious adverse event. It's very rare, and it only occurred in Southeast Asia with prolonged high doses of qingdai use. There is also a very adverse event of a delayed type allergic reaction, which peculiarly manifests as ischemic colitis of the right side or sometimes colonic intussusception. All of these are reversible when qingdai is stopped. We actually started using in Israel back in 2015, so even before the publication by the Japanese, this food supplement in Israel, but we're already aware of some initial reports from Southeast Asia and trying to sort of reconcile the benefit that we've seen with our first patients with this safety profile. We thought of combining it with a curcumin, sort of to be able to taper the qingdai exposure based on disease activity, as you can see on the right. So we devised sort of 5 protocols whereby the amount or the ratio between the qingdai, the more robust moiety, and the curcumin are changed as the patient transitions from more severe disease towards remission, to reduce the long-term exposure of high doses of qingdai. I just want to note that for everyone here on the audience that are mostly dealing with dietary interventions, so curcumin is not turmeric, and this is a common mistake. Turmeric is actually jianghuang. It's a herb that contains approximately 2 to 3% of active curcumin. If you isolate then the active curcumin compound from it, you can end up with a concentration of 95%, which some of the compounds have. We took another step of actually devising a formulation which is gut-directed, and reasoning that actually we're trying to treat with curcumin gut IBD, so mostly want higher concentration in the gut. We don't need all the bioenhancers that are sometimes applied to increase the absorption of curcumin systemically. So what we have done back at the time, even before the Japanese publication, was actually to combine those curcumin with QD. We call it for shortening CurQD. And this is just some of the few examples, again, before even the publication that came out from Japan, and was somewhat disappointing for us, but very much kudos for the Japanese group. So these are some patients' examples from my clinic. You can see on the left a patient that was failing 5-ASA as well as Cortiman, and was about to start vedolizumab, but trying in our integrative medicine clinic that is embedded within the GI department, went on to attempt a short-term CurQD, reported a very fast response, and you can see the mucosal healing that ensued and actually never escalated to biologic, and she's on this CurQD 5-ASA combination up until today. And the other extreme on the right is another patient of mine that was very severe failure of cyclosporine, failure of a combo therapy with infliximab and 6-MP. And on the verge of colectomy, we didn't have tofacitinib at the time, but on the verge of colectomy, we suggested a short-term attempt of CUR-QD, to which you actually responded very well. And you can see the endoscopies within 3 months, complete mucosal healing of this patient. Again, is up until today on CUR-QD and in complete clinical and mucosal remission. So actually in Israel, this has become a very popular compound to add to pharmaceuticals among academic centers. And Professor Yanai from another center has actually accrued and reported first 90 patients from 5 academic centers in Israel. As you would expect from tertiary centers, 50% of these were bio-experienced, and 40% actually failed more than 2 lines of biologics or small molecules. And with the caveat of this being a retrospective study, so always need to take it with a grain of salt, but still you can see that in very refractory patient population, the clinical response rate as well as biomarker response rate were quite significant. We then went on also to do a placebo-controlled trial of this CUR-QD compared to placebo. This was conducted in Israel and in Greece in the University of Athens. And very shortly, as you can see, we randomized patients with a moderate severe active disease despite pharmaceuticals, which could be biologics, small molecules, 5-ASA or the same, to either receive add-on CUR-QD or add-on placebo. And this is an important point to discuss, because I think like many of the dietary intervention that we do, this should also be the rule for most nutraceuticals, that we should always use them as add-on to begin with. And we definitely do not intervene in physicians' discretion to continue the pharmaceutical, even if it's failing at this point. And we can discuss in the Q&A the ideas of mechanistic combinations. But as you can see on the left-hand side figure, so in terms of induction after 8 weeks, the trial met its primary outcome of clinical and biomarker or endoscopic response, as well as clinical response and remission and endoscopic improvement. What's interesting about this CUR-QD, as I mentioned in the 2 short case reports we flew over, is that patients who respond, and not everyone respond, but those who do respond very quickly. And this was documented in the clinical trial by a daily diary. And as you can see, by day 12, already elimination of rectal bleeding occurred statistically significant more in patient on receiving the active CUR-QD. We actually now published a post-hoc analysis of that, and probably all of you are aware of the importance of urgency, bowel urgency as a driver of patient low quality of life in UC patients and some colonic Crohn's disease. So bowel urgency is something that is very detrimental to our patients' daily life. And we looked back at the trial SECAI score, the validated score that was used, which fortunately has a sub-item of urgency. And as you can see in this post-hoc analysis, the CUR-QD compared to placebo also favorably influenced the urgency among patients. So in terms of adverse events, which are always important and for nutraceuticals certainly, and I think it was nicely touched on by Stephanie and Rose also, that some dietary intervention may have those downsides or nutritional deficiencies. So we always have to look at the other side of the coin. So in terms of that, with a caveat again of a small, modest size study, there were no signal for any adverse events in the CUR-QD group. And also we went to the extent of doing echocardiography before and after, and there was no signal for a pulmonary hypertension with this approach of reducing the exposure to QD within this CUR-QD combination. We now have several publications or several evidence about the pediatric population. Just published 2 weeks ago is a multi-center retrospective, again, pediatric study on the left, suggesting similar efficacy as we see in the adults. And Dr. Chavanes, the head of IBD in Children's Hospital LA, has presented in recent CCFA ultrasonographic follow-up of pediatric patients who were given CUR-QD with active UC and showing a nice sonographic response as an objective measure of response. Now, most of the data, as you might have noted, was generated with UC, and this is a majority of our patients, but we're starting to see some publication, and this is something that is in the doing publication from 2 other centers in Israel looking at active Crohn's disease, and you see a response also in Crohn's disease to this intervention. And interestingly enough is that although it's a rather small group of 25 patients, but still if you do a subgroup analysis, as you can see, for patient with colonic involvement of the disease vis-a-vis a patient with small bowel disease, there seems to be a signal for better efficacy of CoQ10 in Crohn's disease involving the colon. And bearing in mind that we know that the genetic composition and transcriptomic composition of patients with colonic involving Crohn's disease is much more similar to UC than small bowel CD, I think this is an interesting hint towards mechanism of action. So speaking about mechanism of action, with a collaboration with Bar-Ilan University next to us, a chemical analytical lab, we were actually able to identify the active molecules within this herbal compound. These are the indigo and indirubin, as you can see on this LCMS mass spec analysis. And interestingly, without delving too much into the science, but what we have found in the rectal mucosa biopsies that were fresh frozen from the clinical trial is that this CoQ10 influences and upregulates the expression of CYP1A1, which is a real hydrocarbon receptor downstream molecule. This was not seen, as you can note, after placebo, and also not seen in patients who outside the trial received biologics or 5-ASA and reached similar mucosal healing. And this is important to show that this upregulation of this molecular pathway is not related just to a reduction of inflammation as an epiphenomena, but rather is probably related to the unique MOA, the unique mode of action of CoQ10, which is not shared by other interventions that we have. This is now corroborated by studies in our lab that have shown in vitro studies that indeed the indirubin and similarly the indigo directly influences an agonistic effect, upregulation of this pathway. Now, in case you haven't heard about the AHR, so this is a real hydrocarbon receptor, is a receptor that is quite prolific in the gut and in other tissues. And very interestingly for this webinar, it's actually a receptor for tryptophan metabolites that we ingest in the diet. So when one ingests tryptophan in the diet, it can go, as you can see on the publication on the left, it can go into either of three pathways in terms of its microbial digestion. And one of them, the indol's metabolite, are ligands, are activators of the real hydrocarbon receptor pathway that downstream is responsible for epithelial reconstitution, epithelial repair, and does not really have a lot with immunosuppression. And that gives us a rationale, the mechanistic rationale of combining this nutraceutical with immunosuppressant or immunomodulators that we use for IBD, reasoning that there is no double immunosuppression with this intervention. Again, I think showing the similarities between dietary intervention along with pharmaceutical and also nutraceuticals if properly tested with a pharmaceutical. Now, interestingly, this AHR has gained a lot of attention recently, and there are now over 240 AHR agonists that are in development by the pharma, by the industry, most of them in preclinical and phase 1 studies. So I think for this audience, it's interesting to see that we started from a dietary food supplement and ended up with a only oral AHR agonist that is currently available, probably 10 years ahead of regular pharmaceuticals that will come along. I think an important aspect, and I apologize for using CoQ10 as an example, but throughout this journey of 8 years, I've learned a lot, and I think it has a lot to do with how we should use nutraceuticals in IBD and other GI diseases and probably in medicine. A lot of it has to do also with access to patient, but a responsible access, because we know we can all go into a nearby CVS and buy a host of nutraceuticals and herbal compounds, and they go without any guidance or any real monitoring, and patients are often as much confused as their doctors or APPs or dietitians. So this is why actually we did, this is related also to my conflict of interest. Shiba founded this Nature as a spin-off company to distribute this, but we deliberately decided not to put it on any shelves, reasoning that indeed, I think as practitioners, we need to really monitor whatever we do with patients. So this is only available on an online platform whereby patients input their SECAI score, the validated SECAI score, or the HBI, they input the comorbidities, co-medication, and dietary habits, etc. And with this very deliberate 61 questionnaire, we then tailor the right protocol for the disease activities, comorbidity, etc., and follow them up every 6 weeks to really tailor the medication. So I think this is an example. Again, I'm not saying it's the best one. I think it's an example of how nutraceuticals and dietary intervention as such should be monitored as best we can. Responsible accessibility also means that we have to work hand in hand when we do dietary intervention, nutraceutical intervention, complementary medicine. So we have to work hand in hand with a medical ecosystem. And this is partly what was done with this particular instance of CrookUD, which is now fully integrated into many leading medical centers in the States and elsewhere, in the sense that many of these centers actually even integrated into the EPIC system, the EMR. Some doctors or most doctors are using it regularly. And recently we even got we were proud to be the first and only actually nutraceutical to pass the ingestible committee of the CCFA, leading to partnership with CCFA. So I'm trying to wrap up and just say this journey was an example. And again, I apologize for this focus after talking with Stephanie before, but I think it shows us that what Severin Vermeer and our group was talking about, holistic healthcare, is something that we should seek. There are many, many options, there are many, many opportunities out there, but it needs to be done well. If it's done well, I think, as mentioned by Professor Ashwin from MGH in the editorial on the trial, I think it is time for us to consider, I'm not sure I like the word alternative, but integrative medicine approaches, such as dietary approaches, certainly are already in the mainstream, but some nutraceuticals can also be considered to be partly supporting. So my take-home message, I think plant-based nutraceuticals are in a way a middle path to support both pharmaceuticals and dietary approaches. And those approaches, those strategies, and I use CrookUD as an example, but there might be some others that are out there or will be there soon, can address not only personal wishes but by patient, but also improve the outcomes. However, it's very important, I think, to underscore that they need to be evidence-based, preferably by placebo-controlled trials that are well conducted. I honestly think they cannot be OTCs. None of our IBD intervention are OTCs in that sense, and even nutraceuticals cannot be something that you take off a shelf in some, as I mentioned, some CVS, but they need to be guided, managed, and monitored by physicians, IPPs, and dietitians. And I prefer that they always be used as adjunct, add-on treatment rather than instead of conventional medicine. So with that, I'd like to really thank you for the opportunity to talk to you, and really enjoyed this fantastic webinar so far. Looking forward to hear more.
Thank you so much. This was such a fantastic talk. There are a bunch of questions, so I'd love to start with these. One of the first questions says, would you recommend cooking with curcumin versus turmeric instead of taking them in capsules? And what do you think of ginger? Are there other spices of interest that are currently being studied?
So both questions are really pertinent. Well, for curcumin, cooking with curcumin, it's very hard to say because, as I said, I think it's all about evidence-based. So we don't know the dosing. For instance, in curcumin was a meta-analysis published that led also to its incorporation for add-on in mild moderate EC by the ECHO guidelines. But in that meta-analysis, if you look carefully, so there were two positive studies. One of them is an old study by us in CGH 2015, another one by a Japanese group, talking now about curcumin alone. And there was a negative study by an Indian group. The negative study, they administered 300 milligram, whereas both the Japanese and ourselves administered 2 grams. So I'm not sure that explains the whole story, but we know in medicine that dosing counts. We know that in dietary intervention, you illustrated that very nicely about the fiber. So I think probably just adding curcumin to the diet probably has little effect, but we don't have real evidence for that per se. Regarding the other question was about ginger. So there is some studies about ginger, not so much specifically in IBD that I'm aware of. A lot about alleviating nausea, which is sometimes something that we do use in some of our, by the way, post-operative patients. But I think even there, the evidence is still not as good as what I would personally like to see. But again, as an innocent intervention, it can be tried sometimes.
Excellent. And the next question says, given the difference between turmeric and curcumin, do you recommend turmeric consumption for your patients in terms of their cooking and food options?
So I hope that the previous question made it, the previous answer made it clear that the answer is no, because turmeric, first of all, you know, in order to ingest 2 grams of curcumin, which is what has been tested, one needs to ingest about 100 grams of turmeric per day.
A lot of turmeric, yes.
So that's part of the problem, I think, that in this nutraceutical landscape, in this space, that there are a lot of manufacturers, and many of them may be I would say sort of good-hearted and meaning the best, but again, there's so much information and misinformation there that in my conception, I think turmeric currently has no evidence whatsoever and doesn't have the dosing mechanism to even explain it. So honestly, I think if one takes curcumin, it should be the 95% pure curcumins that are out there, and not only ours necessarily.
That's very helpful. Are there any biologics or small molecules that you would avoid combining with CoQ10?
So we at first, because of this mild liver elevation, and when we started using CoQ10, so small molecules were new on the, new kids on the block. So we were a bit wary about using CoQ10 with JAK inhibitors, with Rinvoq and with tofacitinib. But now we have gained more and more experience. University of Chicago, I know David Rubin has quite a big series of patients who were partial responders to upadacitinib, and the team there added CoQ10 and sort of fortified the response through this measure. So now we are gaining more sort of assurance, and we allow patients to basically go on any medication with CoQ10.
Perfect. And along those lines, would you advise against using CoQ10 in patients with liver dysfunction and PSC if they have UC?
So this is also an important question. There have been extremely rare case reports of curcumin as opposed to QD that actually cause quite common mild liver enzyme elevation, which are transient. With curcumin, there have been a handful of cases that have shown almost like a fulminant hepatitis. It's not unclear when you go into the data. It's not really clear. The biggest series is 11 patients accrued from many patients taking curcumin, and in the United States alone, about 10% of population takes some form of curcumin or turmeric. So it's very hard to really differentiate where are these handful of reports coming from. But as I agree with whoever asked that question, that I would be very cautious in patients with PSC and with any underlying liver disease. This is also our recommendation with CoQ10, and we often say only done with very strict physician monitoring and very strict enzyme monitoring of blood tests.
And on that same line, thank you. Are there any issues with giving curcumin in somebody with gallbladder contractive, disease?
With someone who
Has gallbladder contractive, like difficulty with the contraction of the gallbladder?
Not aware of any such issue. Interesting question, but I'm never encountered any gallbladder issues with any of these herbals, so probably not.
One of the other questions that was sent to us is a question about whether or not you're getting an echo in patients before starting when you're regular use, just because of this question of pulmonary
So
hypertension.
no, we don't, because as perhaps I don't know if it was mentioned, now in North America, more than 10,000 patients have been treated, and we did not see a single case of pulmonary hypertension. So we suppose this is both because of this production in a GMP facility where everything is very monitored, including the percentages of indigo and indirubin, plus the tapering protocol, whereby as patient progresses, they taper the protocol, so never exposed to long-term high dose of the QD. So we don't routinely do it. However, in the rare cases where patient, as they taper down, they start to flare, and we increase back the doses of the QD and change the protocol. So in those quite seldom patients that really need higher doses, then we do suggest after 6 to 12 months to do an echocardiogram. We have done so in several patients and still haven't seen, fortunately, anything. But this is something that we do recommend after 6 to 12 months if someone continues on higher doses of CoQ10.
And what is considered a higher dose for those patients? Which color would you suggest if they're maintaining on?
So this is, we actually did, again, it's a lot of things that I think is are very interesting for the audience here in terms of how we address our patients and making life easier for them. And I think this is something that we often, even as a physician, neglect to think about with all our different protocols, etc., which can sometimes be confusing and bewildering for patients. We try to make it, apologize, but sort of dummy proof for our patients. And I'm considering myself as a dummy as well, because with my single medication, sometimes I'm getting lost. So in that sense, meaning that you always take the CoQ10, we designed so to take 2 capsules in the morning, 2 in the evening, and that's it. Only the ratios of the curcumin and QD are changed, and we also use the colors that you refer to as another, I think, facilitating the addressing to patient rather than remembering all kinds of intricate numbers of dosaging of grams, etc. But usually more severe patient will be on those higher colors, meaning higher ratio of QD to the curcumin compound. So these are the orange one, the yellow, sometimes even the red. And as they progress and become more and more towards remission, they will go down on the color. So I think this is something intuitive for the patient and very easy to sort of digest, literally.
Yeah, it's a really nice way for patients to see that. One last question in the chat. Are there any other spices of interest that are currently being studied?
So there was a nice study that I was just giving a talk in the Swiss Congress, and we were discussing very nice studies from the group by Gerald Rogler that was done almost a decade ago with bilberry. So it's not a spice, but they had a placebo-controlled trial that was unfortunately stopped in the middle, but previously they had an open label study and mechanistic studies about this bilberries extract. And I think this is something that is very interesting. There is some mechanism of action proposed there. Other spices, as you saw in the review, there are several other, and and omega-3 has been proposed, etc. It's not, again, not exactly a spice, but other nutraceuticals have been proposed. I think the key message that I'm trying to convey, and I'm not sure how many in the audience are patients, how many are healthcare practitioners, but I think we as an IBD community really need to strive to bring in nutraceuticals, to bring in dietary intervention, but do it as much evidence-based as we can. And unfortunately, with some of those interventions, this is something that we still need to work on to really bring it to the level that we feel really reassured about them.
Thank you so much. And thank you again for such a fantastic talk and for answering the questions. So our next speaker is going to be Dr. Maya Kayal. She's an associate professor in the Division of Gastroenterology at the Icahn School of Medicine at Mount Sinai and the Susan and Leonard Feinstein IBD Center. Dr. Kayal's research interests in inflammatory conditions of the ileal pouch, and it's been funded by the NIH, Crohn's and Colitis Foundation, and Rainin Foundation. She's a former ACG Young Physicians Leadership Scholar and AGA Future Leader. She has published hundreds and thousands of articles on J-pouch, and today we'll talk to us about the nutritional recommendations for patients with an ileoanal pouch. Welcome, Dr. Kayal, and thank you so much for joining us today.
Okay, thank you so much, Stephanie, and thank you for putting together such an amazing session today. I feel like dietary considerations in IBD have been lacking for such a long time, and it's so great to finally have just an organized group and organized sessions that can really help us understand how we can optimize our patients with IBD's lives through nutrition. And Professor Sharma, that was a phenomenal lecture. I always learn so much when you give a talk, and it's always so nice to be able to bridge the gap for many patients by bringing, as you said, nutraceuticals into clinical care and clinical practice. So along those lines, my talk today will be about nutritional recommendations for patients with a J-pouch. And this is a field that has been fraught with so much misinformation. And unfortunately, a lot of our patients get their information from Dr. Google, where there's not much homogeneity in terms of what the recommendations should be. And this is a field that both Stephanie and I have felt very strongly about. And I'll show you some slides from papers that we've put out together. And just to also give a plug that we've actually introduced nutritional recommendations formally into our Pouch Plus clinic, such that after patients have a pouch consult and a pouch ultrasound, they meet with Stephanie to review kind of the most up-to-date evidence-based data on nutritional recommendations for patients with a pouch. So I'll go through some of these recommendations today. And here are my disclosures, which are not relevant to the talk. So our aims are to quickly review the stages of restorative proctocolectomy with ileal pouch anal anastomosis, and to better understand the post-operative expectations, as these really set the stage for what we counsel patients. To then discuss the nutrition recommendations that can help optimize pouch function, and finally to explore the different ways that dietary interventions can be used to reduce overall pouchitis risk. So despite improvements in medical therapy, we know that still 10 to 15% of patients will require surgery for their ulcerative colitis. And the most common surgery that's performed in the world is the staged proctocolectomy with ileal pouch anal anastomosis. In the United States, we typically perform this in a 3-stage approach. The first stage is a subtotal colectomy with an ileostomy. After the patient has had time to recover nutritionally and emotionally and physically, they return for the second stage, which is a proctectomy, a pouch construction, and then a proximal diverting loop ileostomy. And then 3 months after that, the patient returns for an ileostomy takedown and a restoration of intestinal continuity. And the reason a 3-stage approach is favored in the US is that studies have shown this is associated with less postoperative complications compared to a 2-stage approach. Now, it's really important to understand the second stage where the pouch is constructed, because this sets the stage for pouch function. So the pouch itself is actually constructed from the distal 30 to 40 centimeters of ileum. The ileal segment is folded onto itself into two 15 to 20 centimeter segments. Then an enterotomy, or an opening, is made at the pouch apex here. And then through this enterotomy, an anastomosis, a side-to-side anastomosis of these two segments of ileum is done, usually by a linear stapler. Then the blind loop of the pouch is stapled closed, and the pouch is then anastomosed to the rectal cuff, which is a residual 1 to 2 centimeters of rectum that's left in place to facilitate this anastomosis. So as a result, we have a 15 to 20 centimeter pouch that's about 4 centimeters in diameter and has an approximate volume of 200 mLs. And it's made up, as you can see, of 2 loops of small bowel that actually have opposing peristalsis. And so the pouch largely empties by gravity. Now, these changes in anatomy and physiology occur largely because of the surgical changes that were done. And these changes have predictable effects that result in a new baseline GI function for a patient. So in the immediate postoperative period, patients will have many liquid bowel movements, sometimes upwards of 10 within the 24 hours, because the ileum is really adapting to its new role as stool reservoir in place of the rectum and the colon. But over the next couple of months, as the pouch adapts to this new role, the frequency of bowel movements really starts to decrease, somewhere to around 6 to 8 within 24 hours, with about 1 to 2 per night. There is still a tendency for urgency, and there is a risk of seepage, largely because of those anatomical changes and the limitations of the pouch as a stool reservoir that we talked about in the last slide. But the truth is, it takes a lot of work to actually get to this point of 6 to 8 bowel movements within a day, with the judicious use of different anti-diarrheal agents and dietary guidance, which is what we'll talk about. And so in light of this altered anatomy, we can imagine that food has a very significant impact on pouch function. And in many ways, it has more of an impact on pouch function than it ever did on the colon or the rectum. And it's important to recognize this early on, because part of ensuring a successful post-pouch course for patients is to help them understand what their post-pouch function and expectations will be. So we want to set the stage about how food is actually very powerful in optimizing pouch function early on. And so here are some kind of just big picture types of foods and the impacts that they have on food, on pouch function, that we share with our patients. We like them to know early on broccoli, cauliflower, Brussels sprouts, cabbage, and similar foods can cause bloating, more so than when they had their colon, perhaps. Simple sugars, chocolate, alcohol can increase their frequency of liquid bowel movements. Fish, onions, garlic, asparagus, eggs can increase stool odor. Certain foods like chilies, seeds, acidic, spicy foods can increase anal irritation and burning. And then other foods can pass completely undigested into the stool, such as corn, popcorn, fruits, vegetables, skins, lentils, and carrots. You can argue, well, isn't this common sense? Doesn't even the patient who doesn't have IBD recognize that things like broccoli can cause bloating and things like corn can pass into the stool undigested? Yes, but you have to imagine and remember that patients with a pouch have that heightened sense of anxiety with respect to their bowel movements after they've had their surgery. They've gone through the trauma of having refractory ulcerative colitis, having 2 to 3 stages of surgery, and now living with a new normal and a new baseline pouch function. So we want to empower them to have the best possible pouch course by letting them know that these things are expected, can occur, and can change their pouch function a bit. And in fact, a number of food survey studies have been done in patients with a pouch and have identified certain triggers for patients with a pouch. And of course, these kind of fall in line with what we historically know. Many patients have associated increased stool frequency, loose stool consistency, and incontinence with foods that are high in fiber or grease, as well with beverages that are high in sugar or alcohol. And more specifically, these studies have identified patients have had actually worse symptoms when they've consumed non-leafy vegetables, spicy foods, fried foods, popcorn, dairy, and they have less symptoms when they've taken foods such as rice, yogurt, and bananas. And then, of course, importantly, and we'll talk about that in a bit, the timing of meals can have a significant impact on pouch function. And we know that later timed evening meals can cause looser stool consistency and increased frequency overnight. And so along those lines, what we tried to do here at the Mount Sinai IBD Center in coordination with Stephanie is come up with clearer dietary recommendations for our patients with a pouch. And the truth is, this guidance is not very complicated. We've presented here a kind of a food pyramid similar to the one that we all grew up learning about, that focuses on the priorities for patients with a pouch. And priority 1, as you can imagine, is that fruits and vegetables should be included in each meal. And texture modification is key here if a patient is having any GI symptoms, such that the fruits and veggies could be peeled, cooked, pureed, steamed, as long as they're just incorporated into the diet. And I'll show data about why that's particularly important for fruits and veggies. Priority 2 should be that we should aim for home-cooked meals as much as possible, limit that processed fast foods that might have additives or preservatives that could have untoward effects towards pouch function. Priority 3 is to include whole grains and starches in the diet, because as we'll show, these can actually help thicken stool and reduce frequency. Priority 4 is to focus on lean protein sources, such as fish, white meat, chicken, turkey, and to kind of limit red meat as much as possible. And the priority 5 is to, of course, incorporate healthy fat sources such as olive oil. The next couple of slides are going to be really about practical tips for the patient, about how they can troubleshoot certain aspects of pouch function. So we know that for many patients, loose bowel movements is particularly troublesome after a pouch. And oftentimes the question that we get is, how can we thicken the stool? Because not only will you thicken the stool and just reduce the discomfort of having constant liquid stool for these patients, but by thickening it, you also hope to reduce frequency and reduce incontinence. So the tips here are to prioritize foods that will thicken the stool. These include starches such as sourdough, oatmeal, rice, potatoes, crackers, peanut butter, bananas, applesauce, but also to avoid simple sugars, which are rampant in all of our diet, unfortunately, whether it's fruit juice, soda, or candy. And then also to increase soluble fiber intake. The question about fiber is tricky because there have been a couple of studies that have looked at soluble versus insoluble fiber. They've been limited by heterogeneity in their study design and their outcomes. And so we don't have a complete answer about kind of which kind of fiber, but we understand just from our clinical care and from the studies that have been most robust that soluble fiber supplements such as Metamucil capsules or cookies seem to be the most helpful to thicken stool. Nocturnal bowel movements are another big issue for many of our patients. And in fact, one of the most common questions that I get is, how do I reduce waking up overnight to use the restroom? And so a lot of this has to deal with timing. And in fact, I think the biggest intervention here to reduce nocturnal bowel movements is to move up that dinner meal and make sure that it's at least 3 to 4 hours before bedtime and not have it be the largest meal of the day. Really, in patients with a pouch, dinner should be a small to moderate sized meal, and breakfast and lunch should be the larger meals. This is largely to allow the pouch to have ample time to evacuate before going to bed, such that the patient isn't waking up many times overnight to use the restroom. It's also important to include a starch in dinner to help thicken that stool, as we talked about in the last slide, and reduce stool frequency. Limit simple sugars after dinner. I know it's very easy, me included, to kind of want that sweet treat right after dinner and before bed. But in these situations, we would caution our patients to consider other after dinner snacks, maybe that include a protein or a starch that could help reduce nocturnal bowel movements. And then as much as possible, avoid caffeine. That is a known trigger for bowel movements. In the evening, still get your morning cup of coffee. Bloating is another big common complaint that we hear from our patients with a pouch. And you know, I want to say that I've actually learned how to manage bloating from the cues that I receive from my patients. A lot of this is with diet, such as reducing foods that we know to produce gas as much as possible, avoiding skipping meals, because when you skip a meal or when a patient skips a meal, the entire GI tract slows down in the absence of food. And so this actually results in the accumulation of gas and bloating. Reducing carbonated beverages as best as possible, and then limit chewing gum, which causes excess air to be swallowed. Something that I've picked up from my patients with a pouch is that a main way that they actually reduce bloating is through yoga. And so daily yoga exercises can actually just help move gas through the GI system and allow patients to evacuate it. There's not enough data to support that yet, but I think yoga is an intervention that we could all use a little bit more of. Now, beyond optimizing pouch function, Food has been studied both as pouchitis treatment and prevention. And this is important because we know that acute pouchitis is quite common in patients who have had surgery for ulcerative colitis, and it actually occurs in up to 80% of patients. And approximately 60% of patients will develop at least one recurrence, and then 20% will go on to develop chronic pouchitis. And we see here, as I've presented, that pouchitis seems to really be a spectrum of disease that ranges from acute to chronic antibiotic dependent, antibiotic refractory to Crohn's disease-like. Now, the pathophysiology of pouchitis as a spectrum hasn't been fully elucidated, but we know from many studies that there seems to be a very core interaction between the microbiome and the mucosal immune system. And in fact, the way that acute pouchitis is predominantly treated is with antibiotics, and patients feel better pretty rapidly. So we know that that microbiome driver is very pertinent in patients with pouchitis. And so the role of the microbiome is a causative factor in pouchitis. And of course, the impact of food on the microbiome has led to much interest in this area. And many studies that have evaluated how can we use food to manipulate the risk of pouchitis. So Iris Tatan from Israel's group has done phenomenal work in this area in a very, really kind of robust and concrete way. This was a cross-sectional analysis of 153 patients who had assessment clinically, biologically, and nutritionally. And what you can see is that they actually followed patients who had a pouch, kind of defined what they were eating, and their adherence to the Mediterranean diet, and then tracked how that diet was impacting different parameters. And so what they found was that adherence to the Mediterranean diet, which was calculated using the MED score, was inversely associated with elevated fecal calprotectin levels, meaning that I said that in a complicated way, but essentially higher adherence to Mediterranean diet was associated with less calprotectin, meaning less inflammation in the pouch. And that Mediterranean diet adherence was characterized by high intake of dietary fibers, vitamins, minerals, and antioxidants. And when they followed a subgroup of patients who actually started the study with normal pouch that essentially had no evidence of pouchitis, and they tracked those patients over time, they found that the patients who had higher adherence to the Mediterranean diet had a lower rate of pouchitis over time. And so this was one of the studies that actually supported using a Mediterranean diet in patients with a pouch, not only because it was associated with less of a biomarker inflammatory risk, meaning less calpro, but also over time, a less risk of pouchitis. Now, from the same group, we also saw that fruit specifically was shown to reduce the risk of pouchitis. Here, this was a prospective study with nutritional and microbial analysis in 172 patients with a pouch. And patients were either defined as having a normal pouch at baseline or active pouchitis. And then they all completed the food frequency questionnaire and had fecal samples that were analyzed for microbial composition. And so this was interesting because it showed that patients who were at the lowest tertile of fruit consumption, that is less than 1.45 servings per day, they had higher rates of pouchitis compared to those who had a higher consumption, greater than 1.45 servings per day. And when they looked specifically to kind of better understand, well, why did these patients have this lower risk of pouchitis in the long term, they found that fruit consumption correlated with microbial diversity and with the abundance of several different microbial genera. So this helps us understand that, yes, the microbiome has a very important role in pouchitis, but more than that, we can actually manipulate the microbiome to reduce that risk of pouchitis. And by choosing certain foods like the Mediterranean diet and fruit consumption, we can promote microbial diversity, and that drives down that pouchitis risk in the long term. But I think for me, I'm always wondering, well, what is a serving of fruit and vegetables? And how can I practically take the information from that study to the clinic? And so in the study, as I mentioned, they showed that fruit consumption greater than 1.5 servings per day was associated with that lower rate of pouchitis. And so I typically show my patients practically what this means. What's an example of one serving of fruit? Because the truth is it's not that much. It can be anywhere from one medium apple, orange, peach, or nectarine to 16 grapes to 4 large strawberries. And so it's not that they have to really completely shift their diet and start to eat a lot of fruits. It's really just subtle changes that might significantly impact their long-term risk of pouchitis. And so this is something that I think is a very high yield, subtle kind of optimization to their diet that can have great long-term impacts. Now, there have been a number of other dietary intervention studies that have been done. We've summarized them here in this table. The issue is that they've been heterogeneous, both in their trial design and their interventions and their outcomes. And so we've had inconsistent results. The studies have examined different dietary interventions, anything from specific food groups like the low FODMAP diet to complete food modifications such as enteral nutrition formulas. They've also looked at whole foods and the Mediterranean diet, as we discussed, but also consumption of like a single food item such as exclusive enteral nutrition. And we've presented both the outcomes and the findings here, and you can see to a certain extent each of these studies has shown some efficacy for patients with a pouch. I think the biggest takeaway here is that there does seem to be a role for partial enteral nutrition for patients with a pouch in reducing stool frequency. And partial enteral nutrition is really defined by protein shakes that contribute to a minimum of 50% of the consumed calories. And so in patients that are particularly symptomatic, with increased stool frequency, who you've treated for pouchitis but continue to have increased stool frequency, I think from this slide, the takeaway is that you could consider partial enteral nutrition. But I think as a larger point to consider is that many of our patients with a pouch auto-restrict because they're so worried about the different impacts of foods on their pouch function. And so if you are considering partial enteral nutrition, you want to make sure that you're working with a great nutritionist who understands the risks, benefits of starting partial enteral nutrition in a patient who might already be restricting their diet in other ways. Because we do want patients to have a good quality of life and to enjoy food and enjoy their nutritional intake, and we don't want to overly excessively restrict. Now, along those lines of the different dietary interventions that could manipulate the microbiome, of course, there's been a lot of interest in probiotics. VSL3 has been the most well-studied probiotic. This is a mixture of Lactobacillus, Bifidobacter, and Streptococcus. And it's actually been studied both as primary prophylaxis and secondary prophylaxis. So in the study the figure that I present here on the left, this was a randomized controlled trial of 40 patients who had pouch surgery. And then they received VSL3 or placebo for 1 year, with the goal here to prevent pouchitis, so as primary prophylaxis. You can see that 90% of the patients who were treated with VSL3 remained pouchitis-free, compared to only 60% of the patients who were treated with placebo. VSL3 was then studied as secondary prophylaxis. This was another randomized controlled trial of 36 patients. These patients had antibiotic-dependent pouchitis. Their remission was induced with a combination of Cipro and Flagyl, and then they were started on VSL3 to prevent recurrent pouchitis. You could see that 85% of the patients in the VSL3 group remained pouchitis-free, compared to only 6% of the patients in the placebo arm. Now, unfortunately, this data hasn't really been replicated in real world, despite many studies, both with VSL3 and with other probiotics. And so, given the cost of VSL3 and how expensive and cost prohibitive it could be for some patients, I don't tend to immediately recommend VSL3. Many patients come in asking about probiotics, and what I do is actually spend the time to go through the limited data. And rather than encourage one specific type of probiotic, if the interest is there, I actually recommend natural sources of probiotics. So I spend a lot of time on discussing the food pyramid, but also talking about different strategies that they can incorporate both pre and probiotics into their diet, such that including onions, leeks, garlic, dandelions, kefir, kombucha, Greek yogurt. These are all great natural sources of probiotics that would be actually more cost effective than VSL3 until we have more data to support its rigorous use. So I hope that I've conveyed to you that food can be used to optimize pouch function, and we need to give our patients this data early on to empower them with the ability to optimize their pouch function. And texture modification is key in this situation. The Mediterranean diet and fruit consumption has been associated with a reduced risk of pouchitis. This is the most rigorous data we have to support nutritional recommendations in this context. And there may be a role for probiotics, specifically in the secondary prevention of pouchitis, but we still need a lot more data to support this recommendation. And thank you so much for your attention.
Thank you so much, Dr. Kyle. That was such a great talk. There are a couple questions for you in the chat, so I will go through them. The first is, can you explain again why it's a good idea to not skip meals in terms of managing bloating? Person wrote that they've read once that fasting may activate migrating motor complexes in the gut and may improve bloating. But what has been your experience with bloating and fasting?
So, I think number one, everybody will have a different response to whatever lifestyle modification they make. And for many patients, fasting is helpful in reducing the stool frequency 100%, such that, patients might kind of auto fast before they're going on a long trip, specifically to reduce that stool frequency. But I think bloating is unique in that when patients fast, and again, everybody is different, but for the most part, when patients fast, your gut is just sitting there empty. And so it's allowing the bacteria to propagate and gas to be produced. And there's really nothing, in a simple term, there's nothing for the gut to do other than to make gas. And so that sensation of bloating becomes very, dominant. So that's really kind of why we tell patients not to skip meals or fast for prolonged periods of time. And I think the key here for pouch function is avoidance of like very large meals, one large meal a day, where then you will have a lot of bloating and you will have a lot of stool frequency because the gut has been, hasn't had anything to do until it's seen this meal, I think is key. And that's why small, frequent meals might be better.
Absolutely. No, I totally agree. That bloating usually leads to overeating later. The skipping meals leads to a bigger meal. And so it's the two together can be really challenging for our pouch patients. There are a couple of questions here about the differences between VSL3 and VisBiome. And I know you touched on this, but are you recommending either? It sounded like not VSL3. Are you recommending VisBiome, or is it more of a food-based approach?
I'm not. I see the points that people have made in the chat. I'm not really recommending either VSL3 or VisBiome. The issue is that we just don't have rigorous testing after those initial RCTs, and they are quite expensive. And so for many patients, cost can be an issue. And without kind of confirmed benefit to justify that cost, I just think that there is more ability to manipulate the microbiome with diet and with just natural sources of pre and probiotics.
Absolutely. There's another question here in the chat about how you introduce fiber in terms of fiber pills. Do you ramp up, or do you just give the dose all at once?
I definitely ramp up. I don't give it all at once because everybody, again, will have a unique experience with fiber supplements, especially. I typically, and remember, they're offered in many different ways. They're offered as capsules, they're offered as powder, they're also offered as cookies, and patients might have issues with one texture over the other. So I typically say, if I'm recommending capsules, which I think for many is the most tolerated, I typically say just start with one in the morning and see how you respond. And if you don't have significant bloating and you're seeing a positive response in terms of stool thickening and reduction in stool frequency, we can continue to increase to 2 capsules a day. But ultimately, it's really depending on how the patient responds.
Absolutely.
Stephanie, can I ask a question?
Of course, please.
Maya, that was fantastic talk. I was wondering about the point you've made, and when we all know it, that patients wake up at night for some of those bowel movements, and I think that's extremely detrimental, for quality of life, waking at night for bowel movements. Do you have any idea about some innovative way of changing the diet at the Last Supper or at a dinner to sort of slow the bowel transit, even at the expense of some risk of more bloating in the morning, like overloading, for instance, with some fibers before going to sleep, or vice versa?
Yeah, no, I think that's a good point. And I think you're right. That's what we spent a lot of the visit talking about, is how to reduce that nocturnal frequency. So other than moving that last meal of the day to earlier in the day, such that they have, a good 3 to 4 hours to evacuate before they go to sleep, I do tend to advise fiber, but mostly starch incorporated into that last meal. It just helps reduce that frequency overall. I didn't mention it here because this is predominantly a nutrition talk, but a lot of patients still need 1 to 2 doses of antidiarrheal right before they go to bed. I find like a dose of, loperamide or a dose of Lomotil really can help reduce that frequency. But there is a lot of power in making diet changes and adding starch and fiber, and then just shifting that last meal of the day to a little bit earlier. I think you can really cut down on that nocturnal frequency quite a bit.
Cool, thanks.
When you're giving that last dose of antidiarrheal, are you giving it with dinner, or are you giving it literally right as they go to bed?
I actually give it right before they go to bed. I usually say like 30 to 60 minutes before they go to bed.
Perfect. There's one last question here. Are patients with acute severe UC who undergo a subtotal colectomy are usually incredibly sick and nutritionally deplete? Should we be focusing on nutritionally optimizing these patients who have undergone their subtotal colectomy with endoleostomy before the second or third
Oh,
stage
yes.
of their J pouch? And is there data suggesting that those who are more nutritionally optimized in this period have improved outcomes in terms of either surgical or pouchitis?
So 100% they should be nutritionally optimized. And I think that's a big, one of the reasons why this surgery is done in a staged approach is to give patients ample time to recover physically and nutritionally. And remember also many of these patients have been on steroids. And so we want to kind of taper those steroids off in this period of time. I'm not totally, I haven't seen data that shows that nutritional optimization in between the stages of surgery has an impact on long-term risk of pouchitis. But we know from just broader IBD surgery literature that improved outcomes are associated with patients who are nutritionally optimized. Whether that carries over into like long-term risk of pouchitis, truthfully, I'm not sure, and I don't think it's been looked at. But the reason this is a stage surgery is to give patients that ample time.
Absolutely. Thank you so much. This was such a great discussion. So the
Thank you.
next talk will be from Dr. Dina Pazer. She's an assistant professor of psychiatry in the Center of Excellence for Eating and Weight Disorders at the Icahn School of Medicine at Mount Sinai, and she's a licensed clinical psychologist. Dr. Pazer specializes in the assessment and treatment of children, adolescents, and adults with restrictive eating behaviors, and has a special expertise in diagnosing and treating our avoidant restrictive food intake disorder, or ARFID. Dr. Pazer is going to talk to us today about ARFID assessments and treatments in patients with IBD. So thank you so much, Dr. Pazer, for coming, and we're very excited to see your talk.
Thank you. Thank you for the introduction and for having me here today. So today I'll be talking about taking the fear out of the fear of eating, ARFID assessment and treatment in patients with IBD. And I have no relevant disclosures. So the two primary objectives of today's talk are firstly to understand the diagnosis of ARFID and the current available treatment modalities, as well as to recognize the diagnostic and therapeutic challenges posed by ARFID in patients with IBD. We'll discuss what the diagnosis of avoidant restrictive intake disorder is, as well as the interplay of ARFID and IBD, and then discuss some assessment and treatment options, as well as what we do at Mount Sinai Eating and Weight Disorders program. So avoidant restrictive food intake disorder, or ARFID, was introduced into the DSM-5 in 2013. And this diagnosis captures clinically significant eating or feeding disturbances that leads to significant weight loss or failure to achieve expected weight gain in younger or growing kids, persistent failure to meet nutritional and energy needs, dependence on enteral feeding or oral nutritional substances, or marked interference in psychosocial functioning. And so this can look like not being able to eat lunch at school, at a birthday party, at work, while traveling with friends or spending holidays with family. The restrictive eating is not explained by lack of food or cultural practices, and the core feature that distinguishes ARFID from other eating disorders such as anorexia and bulimia is that there's no evidence of shape or weight concerns. In fact, many patients are actually looking to gain weight. And finally, the eating disturbance is not attributable to a concurrent medical condition or not better explained by another mental disorder. And so to evaluate whether an individual with a GI disorder meets the diagnostic criteria for ARFID, it's going to be necessary to determine whether the symptoms of eating or feeding are beyond those expected to occur with a GI diagnosis. And so the DSM outlines 3 different potential profiles of food restriction and avoidance. The first is due to sensory sensitivity to taste, textures, temperatures, smells of food. The second is lack of interest in food or eating. And so these individuals might not get hungry or may require external cues or prompting to eat. And the third is fear of aversive consequences. So this may follow an aversive event like choking, vomiting, abdominal pain, bloating. And this is likely the profile that most closely overlaps with patients with IBD. These presentations are not mutually exclusive. Individuals with ARFID often present with more than one presentation. In a recent publication in The Lancet, it was found that among over 300 children and adolescents with ARFID, the majority of patients had a mixed presentation of subtypes. And so with regard to common preferences in individuals with ARFID, we often see a preference for a certain color of food, most commonly white foods, even certain brands of food. So someone may be able to eat one brand of chicken nuggets, but not another. There may be certain texture preferences. So if an individual says they eat pasta, they may only be referring to one shape of pasta. Mixing foods is another area that's challenging for individuals with ARFID. So I've heard from several patients that they prefer foods to be uniform texture throughout, like not eating chocolate chip cookies, or very smooth foods. So even having discomfort with tomato sauces, or going so far as to wipe tomato sauce off of pizza underneath the cheese. And even proximity to food can be challenging. So food that elicits a disgust-based response in individuals with ARFID can be challenging even to be in the same room as. ARFID is a newer diagnosis, so data are limited. With regard to prevalence, estimated 0.5 to 5% of the general population would meet criteria for ARFID, both in adults and children. 12 to 21% among patients with GI disorders, including 14 to 53% of adults with IBD. And these may be overinflated due to active GI symptoms, but we'll talk about that a little bit later. There's also high rates of psychiatric comorbidity, particularly with anxiety disorders and autism spectrum disorders. ARFID is a very heterogeneous disorder, so it can be diagnosed at any age, though the average age of diagnosis is between 11 and 14 years. It is more common in females than in males, though compared to other eating disorder, the proportion of males is highest. There is a longer duration of illness with ARFID compared to other eating disorders, and this may be because of the earlier onset of disease. And with regard to weight category, ARFID really spans the weight spectrum. I want to take a moment to explore the biopsychosocial model explaining clinically significant food avoidance and restrictive eating patterns that we see in ARFID based on work published by my colleagues, Dr. Hildebrandt and Dr. Brown. So in this model, an underlying biological vulnerability interacts with learned food avoidance. And these biologically based vulnerabilities in ARFID may include those three profiles that I discussed previously. So the heightened sensory sensitivity to food, the lack of appetite or interest in food, and a heightened central nervous system response to anticipation of future negative events, vomiting, GI discomfort, choking. And so these vulnerabilities may create a negative environment around food and eating, where the individual with ARFID and parents, when it comes to children and adolescents, experience eating as difficult both physically and emotionally. And so patients then learn food avoidance through two stages. In the first, through classical conditioning, eating and even the food environment becomes associated with an aversive state. And in the second, food avoidance and escape from that anxiety or discomfort before and after eating is then negatively reinforced via operant conditioning, whether through parental accommodation in children by not giving unwanted foods, or in adults by realizing if they don't eat certain foods, they won't get sick or be fearful of getting sick. So food sensitivity leads to food disgust, which leads to food avoidance. And while evolutionarily, this may have been adaptive to prevent people from eating poisonous foods, in the case of ARFID, the disgust-based food avoidance generalizes to situations that are not dangerous, and therefore it becomes pathological. So why is ARFID relevant in patients with IBD? Crohn's disease and ulcerative colitis, as you know, are chronic inflammatory disorders with symptoms that may be triggered by diet. And so diet modifications and food avoidance, as we've heard, are common in IBD, whether prescribed or self-imposed, to reduce disease-related symptoms, avoid food triggers, and control inflammation. But some patients continue to avoid even during remission. In one study with IBD, 92% of patients reported avoiding one or more food while having active symptoms, and 74% continue to avoid one or more foods even in the absence of symptoms. ARFID eating patterns may often worsen symptoms of IBD. So food choices and extreme food avoidance can contribute to delayed gastric emptying, bloating, and fullness. And patients with ARFID often favor refined carbohydrates. In one study of ARFID patients ages 9 to 22, patients consumed 68% of the amount of fruits and 53% of the amount of vegetables compared to healthy controls. And so there has been limited research about ARFID in IBD, with limited data suggesting wide estimates of prevalence of ARFID in IBD, more common in active IBD. In one study from MGH, among 101 ulcerative colitis patients in remission, 11% had positive ARFID scores. In another study from the Mayo Clinic in Florida, 10% of adult IBD patients had positive ARFID scores, and patients with severe IBD, as expected, were more likely to have positive ARFID screens. In a study from China, 33% of IBD patients had positive scores, which was associated with poor food literacy and active IBD. And in a study from UCLA, 17% of patients with IBD had positive ARFID risk scores. And all four of these studies used the 9-item ARFID screening measure, which is a measure that goes through the 3 subtypes, 3 questions on each, distinguishing different ARFID presentations. And it's the primary questionnaire used for ARFID screening among GI populations. So we can conceptualize the link and problematic relationship between IBD and ARFID as a challenging cycle. IBD flares may lead patients to restrict their eating, which in turn leads certain patients to be conditioned to avoid foods and develop pathological restrictive eating, or ARFID. ARFID in turn then may exacerbate malnutrition, which is particularly concerning, as we've heard, in patients with IBD. And then malnutrition in IBD is common and a major risk factor for disease complications and surgery, which may then again contribute further to restricting eating habits. And so there are challenges in both diagnosing and treating ARFID in the context of IBD. So clinically restrictive food intake may actually be missed in GI practices. In one study, 71% of patients were prescribed a low FODMAP diet while already meeting criteria for ARFID or showing medical signs of problematic nutrition. And so the question becomes, how do you distinguish between adaptive IBD-related restrictive eating and pathological restrictive eating? And the 9-item ARFID screen, while it can detect avoidance or restrictive eating, it doesn't diagnose, and it also can't differentiate whether the degree of food avoidance is beyond what would be expected in the course of GI disease, and it may overestimate if there is active GI disease. So how do we distinguish between ARFID-induced GI symptoms and IBD-induced GI symptoms when the presenting problems, early satiety, loss of appetite, fear of GI symptoms in response to eating, and food avoidance are so common? There are also challenges in treating ARFID in the context of IBD. So what we often see in our practice is that patients with ARFID and IBD may actually prefer to avoid eating certain foods rather than risk the GI discomfort or feared complications associated with bringing foods back into their diet. Also, foods preferred by patients with ARFID may not be optimal in the context of IBD. And so clinicians treating ARFID in patients with IBD would benefit from understanding and collaborating with the GI to really get a sense of the GI restrictions and diet modifications in order to guide therapy and specifically food exposures. When it comes to ARFID assessments, ARFID is a newer diagnosis, and so a lot of these assessments are either newer or still being developed and validated. But I want to highlight the semi-structured clinical interview, the EDA-5, which was developed by my colleague, Dr. Robin Sisko. This is a short online semi-structured clinical interview that can be used to diagnose ARFID and can be a starting point. We have a number of self-report measures, and I did already highlight the 9-item ARFID screen, which is most commonly used in the field with patients with GI disorders. And we also always collaborate very closely with the referring clinician, the GI, pediatrician, or MD. And when we see patients, we always ask for growth curves, as well as for the medical provider to be monitoring vital signs, nutritional deficiencies, electrolyte imbalances, etc. In the clinical interview with patients, I always really make sure to try to get a sense of exactly what the patient is eating. So I'll always ask patients for either a 24-hour food recall or a typical day of eating to really get a sense of what has been going on most recently. I ask patients about any major food groups that are avoided: carbs, fats, proteins, fruits, vegetables, meat, dairy. And I would say that most commonly I see proteins avoided and fruits and vegetables. I ask about sensory concerns related to food and eating, texture sensitivities, taste, smell, color, as well as any aversive consequences that may be happening due to eating, choking, vomiting, abdominal pain, diarrhea, nausea, bloating. So there are a number of psychological treatments for ARFID that are being developed. Most are based on smaller sample sizes or case reports have been published. There is cognitive behavioral therapy for ARFID, family-based therapy for ARFID, and this is based on FBT, which is the leading evidence-based treatment for anorexia, and feeling and body investigators for younger children with ARFID. I want to highlight what we're working on in our clinic, which is mindfulness-based interoceptive exposure for ARFID. And so our group recently developed and tested this brief mindfulness-based intervention for families and patients with low-weight eating disorders or anorexia, and we've since applied it and adapted it to patients with ARFID. And so this is a disgust-based intervention. We understand anxiety, or the broad anxiety model, as being based on 3 types of anxiety: fear, worry, and disgust. And disgust is the profile that most closely is associated with patients with ARFID, that bloating, nausea, feeling sick and queasy when eating. The treatment focus of ARFID treatment is firstly nutritional rehabilitation. So for underweight patients, we focus first on weight restoration on preferred foods. And for patients with nutritional deficiencies, we focus on reincorporating those foods into their diet. And we also secondly focus on expanding food variety through learning to tolerate disgust related to food and eating. So the therapist works with the patient and parent in the case of children and adolescents to develop what we call a functional food hierarchy. And the goal of the hierarchy is to develop a list of foods that the individual avoids, but would be functional for them to eat in their lives. So for example, typical dinner foods, foods eaten at a birthday party or in the school cafeteria, or in the case of IBD, foods that may help reduce symptom presentation or that have been recommended by their GI. And so as part of the hierarchy, we assess distress elicited by the food, avoidance of the food, and functionality of the food. So if there's a food that elicits maximum distress, but is not functional, like sardines, for example, this would not go on the food hierarchy. And the hierarchy is an iterative process. So foods get added along the course of treatment, and it gets reviewed weekly and then incorporated into the interventions. So with regard to treatment strategies, one of the main treatment strategies is interoceptive exposure or food exposures. And we're really focused on helping patients learn to tolerate the visceral or internal feelings associated with food of eating. So many patients explain that they actually like the taste of food. Some don't, some gag in response to certain tastes. But many patients like the taste of food, but it's that bloating and disgust feeling associated with food that is most challenging for them. We also focus on counter conditioning techniques. So if you remember from my earlier slide about how eating becomes paired with an aversive consequence through classical conditioning, and food and mealtime becomes very unpleasant, we like to associate those two things, eating with rebranding as something more enjoyable. So in the context of therapy, I may have a patient play their favorite song while eating a challenge food, or we play card games in session to make the experience more pleasant. We also use mindfulness-based techniques, so practicing using neutral and non-judgmental language to describe food. So rather than saying, that food just makes me think about diarrhea or throwing up, we'll use language such as, for pasta with meat sauce, we might say it's stringy white texture with some red sauce on top to really take away any judgment from the food. And ultimately, our goals are to reduce avoidance, to learn to tolerate the internal sensations associated with eating and that disgust-based response, and to learn to eat in a more regular and flexible manner. So to eat foods needed to maintain a healthy weight and nutrition, to be able to engage in age-appropriate social activities, like be able to go to birthday parties and play dates or work functions, and to eat with respect to IBD treatment recommendations. At Mount Sinai, we offer individual treatment for adults, family-based treatment for adolescents, and group therapy and parental support groups, both in person and on Zoom. And so I want to close with some clinical care points to think about in your practices and our practices. So GIs may benefit from screening IBD patients for eating disorder risk prior to therapeutic dietary approaches being prescribed or recommended. So if there are concerns about restrictive eating, rigid eating patterns, or anxiety around food intake, consider referring to a psychologist for evaluation before initiating diet modifications. It's also important to monitor the patient's eating habits while they're on therapeutic or altered diets, and to review the duration of the intended diet, the therapeutic goals, and criteria to liberalize the diet when appropriate. To regularly assess the degree to which patients are restricting, and to assess lingering restricted diet after the acute IBD episode when diet modifications may no longer be recommended. Ultimately, a multidisciplinary approach is always ideal with nutrition support to provide guided, focused diet modifications to prevent patients from taking on additional restrictions on their own due to being precautious or a lack of understanding, and to consult with an eating disorder therapist so that the disorder therapist understands the medical restrictions prior to starting therapy. And so, as you may have seen from today's talk, there are more questions than there are answers in terms of ARFID in general, and certainly in specialty populations. And so, this provides a great opportunity for collaboration with IBD providers and eating disorder specialists, and also lays the foundation for research opportunities such as developing dedicated diagnostic criteria for ARFID in patients with GI diseases and evidence-based treatment programs in patients with GI diseases. So I want to thank you for having me and my team at Mount Sinai Eating and Weight Disorders program, and I'll open it to questions.
Thank you so much, Dr. Pazer. That was a fantastic talk. We learned so much. There is a question here in the chat a little bit about how we identify patients who we should call an eating disorder specialist. So I think we all see these patients where they say, I ate a Brussels sprout and I got a bowel obstruction. I won't eat any more Brussels sprouts. And while that seems like a very normal response, where do we draw that line between the pathology of now I'm not eating any fruits and vegetables? So how do we know when to call versus what's just a normal pathologic response to eating?
It's a great question. I think, first of all, you're always welcome to call because it's not so simple. And I think the bottom line is it does require a greater evaluation. When it comes to ARFID, if it's causing weight loss, if it's causing nutritional deficiencies, or really the key is often that it impacts their life, that's when it becomes something that we're concerned about. So if it's one food and they don't like Brussels sprouts, they had a really bad experience, that's okay. But when it is generalizing to all fruits and vegetables, and it's really a fear-based avoidance response, I think there's no reason not to engage in some therapy.
Absolutely. And that takes us to the second question here, just about finding resources to get access to and to connect with eating disorder therapists. Do you have any suggestions? I know sometimes access to care can be challenging in terms of insurance coverage and all. Is there anything that our practitioners on the call today can do to try to make sure they can link up with an eating disorder specialist for their patients?
Yeah, so access to care is always a bit complicated. I would say feel free to always reach out to me directly. We often have ongoing studies where we offer free treatment. We always have groups, parent groups, individual support groups. For children and adolescents, we have trainees who see cases. So we do Zoom therapy and in person. So I think there's generally a way to get patients into care. I'm always available even, as Dr. Gold knows, for consultation. And so we can start there and then figure out the best course of action.
Fantastic. Are there any other questions in the chat or anything else anyone wanted to ask? All right. If not, thank you again for such a wonderful talk and talking about something that we all see in our practices but know so little about. So we appreciate it.
Thank you.
So I'm going to end the session today with a talk on the pearls and pitfalls of nutrition and IBD care. And I really want this to be like the very clinically relevant points that you need to know to bring back to your practice. So the first point, as you've seen today, is that fiber is likely your friend and not your enemy. And we talked about this swinging pendulum of fiber, where we want to prioritize texture modification over restriction. Remember that dietary fiber can improve the gut microbiome in terms of dysbiosis, it can improve GI symptoms when you use it appropriately, and reduce inflammation through fermentation and production of short-chain fatty acids such as butyrate. It's probably more complex than just soluble and insoluble, and you see these dietary sources on the right. And remember, looking forward, we want to think about precision nutrition. How do we identify the right patient to get the right form of fiber during any point in their disease course? A patient who gets fiber when they are in remission and have quiescent disease may be very different than somebody who has active inflammation. And this was demonstrated by the work by Heather Armstrong's group. We want to prioritize whole foods and not processed foods. So you've seen a couple of slides today about the Mediterranean style diet, plentiful fruits and vegetables, whole grains, lean proteins, specifically fish, nuts and seeds, and prioritizing use of olive oil, and avoiding saturated fats, emulsifiers, artificial sweeteners, and colors. I love this article from our colleagues from Nature Review and Gastro and Hep from Kevin Whelan's group, showing the different impacts of these various components on the epithelial cells and the inflammatory system. And there's really been a big push in IBD to reduce ultra-processed foods and thickeners and emulsifiers and sweeteners in order to improve outcomes. Don't over supplement. I think this is a big thing for us. There is a lot of heterogeneity in the supplements that our patients are taking, and this can lead to inconsistent findings in the studies. Unfortunately, there isn't great evidence for the use of supplements such as CoQ10, collagen, cod liver oil, and hemp oil. And why should we stop these? I talked to our patients about cost, side effects. Some of these can cause nausea, vomiting, diarrhea, joint pain, which may overlap with their IBD and they may think is their IBD. Sometimes these supplements are challenging to take in terms of timing. They can limit their whole food intake because they're taking this pill here and then they have to wait and take another one. And then you always want to consider interactions with meds. Here at Sinai, I prioritize patients to take a multivitamin. Any multivitamin is okay. In those patients with malabsorption, I do prioritize a chewable multivitamin. And then I supplement based on needed. I check their micronutrient levels, which we'll talk about. And then based on their labs, I provide supplements. So texture modification, we talked about this for active symptoms, strictures, ileostomies, history of bowel obstructions. So you want to choose those softer, smoother textures. Creamy peanut butter over peanuts, hummus over chickpeas, a nice soup over a raw vegetable, smoothie, etc. And this also goes into your meats as well, thinking about softer ground meat as opposed to a big fatty heavy steak, sliced breads instead of bagels. We've seen plenty of patients have a bowel obstruction or have an obstruction after an their ileostomy from a bagel, from a really heavy meal. So very important to think about these lighter, softer textures. And then remember, as Rose told us, to transition back to a regular diet when possible. You don't want to leave these patients on this very soft texture if you don't have to. So just thinking about with any food, there's really a nice transition, whether it's from applesauce to a peeled apple to an apple with full peel, from a broccoli soup to nice cooked and soft broccoli to a raw broccoli salad. And so we can think about these in our patients as we transition them back, whether they've had surgery or if they've had an obstruction, if they're having active symptoms. And ultimately, our goal is to get them back to these textures, assuming they don't have a known fibrotic stricture, a history of a bowel obstruction, they have an ileostomy, where we would then have them get back to here. But we don't want to leave our patients on the soft purees if possible. Not oral rehydration solutions are the same. So the World Health Organization has actually created this optimal oral rehydration solution to maximize absorption, and that's based on the sodium and the glucose ratios. There are a lot of products on the market. Some are marketed towards kids, other towards athletes, and I'm sure your patients are asking about them. There are variable amounts of glucose and sodium in all of these products, and we try to avoid anything labeled sugar-free or zero sugar, as you actually need some glucose for absorption. Remember that the products that are low in sodium or too high in sugar will need additional salt to balance out that ratio. And so these are the products we recommend here at Sinai. We want to identify products that can be consumed off the shelf if possible, makes it easier for our patients. We use a lot of drip drop and liquid IV. In the hospital where drip drop and liquid IV aren't available, we use Gator Light, and then we often add a pinch of salt just to get those ratios to be as close to possible as the World Health Organization recommendations. Use shakes for healthy weight gain. So a lot of our patients are underweight, looking for weight restoration from a flare where they've lost some weight. Healthy weight gain, we usually target an additional 250 to 500 calories per day. This can be hard for patients. They're already cooking for a family. They may not want to have to make extra meals. Food is expensive. So for some of our patients, this can be as simple as adding in one shake per day. The shakes come as dairy and non-dairy based formulas. As many of you know, majority of them are kosher. Most of them are lactose free. There's no need for peptide and elemental formulas here. And in almost all of these patients, the shake should be taken orally. There's really very few roles for tubes in our patients with IBD who need some oral nutrition support. And you want to choose the shakes not just based on what's available on the market, but choose it based on their nutrient needs and their medical history. So instead of giving patients a buffet of shakes to offer them, which can be overwhelming, provide 2 or 3 shakes that are right for them based on their medical needs. Do they have concomitant diabetes, renal disease, SIBO, kidney stones? These are all things we want to take into account when we're choosing our shake. How many calories do they need? What is their bowel length and their anatomy? We've had pretty good success here at Sinai getting these shakes through the insurance via prescription, which reduce the cost, as well as the patients don't need to go to the store and carry them home because they can be very heavy. And I will say that getting them through insurance has greatly increased compliance with patients drinking these shakes. If you're considering dietary therapeutics, something we didn't touch much on today, but you always want to make sure you're identifying the correct patient and the correct diet. So as many of you know, there are numerous therapeutic diets available, such as SCD, CDED, EEN, but you want to make sure you know who the right patient is. So if you have a patient who's starting on a biologic and looking to add nutrition to that, I always think about partial enteral nutrition here. There's some excellent data that showed that partial enteral nutrition plus Remicade was much more effective than just the Remicade alone. If you have a patient with a terribly busy work schedule, you're going to want to rely on pre-made formulas. They're not going to be cooking every meal at home. They're not going to make their own yogurts. Do you have a patient who enjoys cooking and has the resource to do that? Then a whole food diet would be a great choice. And in our ileostomy and J-pouch and ileoanal anastomosis patients, I tend to favor a diet that is either whole food based or whole food plus formula, but not exclusive enteral nutrition. And that is because the formulas tend to cause a fair amount of diarrhea with this anatomy. Of course, before starting any restrictive diet, you want to screen for eating disorders, and that patient should not be started on a therapeutic diet. And I always say I want to ensure the diet is only being used for the minimum necessary time. So I look at these diets as a way to bridge to a new therapy or for induction of remission, but they are not long-term options. And I treat a therapeutic diet as I would a new medication or a new biologic. I explain to patients if we started you on a biologic, we would never wait and not test for biomarkers and do a colonoscopy to assess for disease response. And similarly, we should do the same with a diet. So instead of a treat to target scope, we call it an eat to target evaluation. Hold off on probiotics. I know Dr. Kyle mentioned this, and this has been something that we've also done in our practices. The data on probiotics, as you saw, is quite variable, and there's no clear, strong evidence supporting their use. There were those few initial studies in using probiotics in patients with the J-pouch. However, these studies have not been reproduced. So we currently don't recommend specific probiotics because we don't want our patients to get 1 or 2 different species in a desert, as you see on the top, but our goal is for like a wild garden with lots of flowers and diversity. And so we really prioritize a varied diet and probiotic containing foods. There's literature to suggest that targeting 30 different plant foods per week can be helpful, and this can be a fun challenge for patients. They can come up with a list of what they've eaten, and it also increases the variety they're eating and their families. We try to get our patients to have yogurt or kefir and fermented foods as well. So we want patients to get micronutrient assessments, but based on their patient history. I don't like to send just a wide panel of micronutrients for every patient, but I like to think about where's their disease, what's their anatomy, what are they eating, what's their clinical history, and are they on medications that would impact nutrient absorption? So as you saw, if they're avoiding fruits and vegetables, we're getting a vitamin C level in those patients, and we'll supplement if it's low. Interestingly, patients on a gluten-free diet often have B vitamin deficiencies, zinc, and iron, and that's because the gluten-free alternatives are often not as well fortified as the gluten-containing versions. If patients have diarrhea or an ileostomy, should be checking their electrolytes regularly, monitoring stool output, and getting a zinc and magnesium and phos as well. If they have a draining fistula, you should be considering vitamin C and zinc levels. Anybody with pancreatic insufficiency or who's noting steatorrhea, you want to check your fat-soluble vitamins. If they have a history of an ileal resection, I see plenty of providers ordering a vitamin B12 level, but the other B vitamins tend to fall off, so I would just think about B1, B6, and folate. And then remember that if patients are on medication, if they're on methotrexate, you want to check their folate, INH, consider B6. And with cholestyramine, you really worry about the fat soluble as well as the other vitamins. So making sure they're separating it from taking any supplements and then checking those vitamins to make sure they don't need additional supplementation. And then finally, want to screen all patients for malnutrition. This is incredibly important. We know that malnutrition affects about 30% of patients seen in the clinic and 70% of those who are hospitalized. And malnutrition is independently associated with poor outcomes, increased post-op complications, disease flares, and poor quality of life. The ESPEN 2023 guidelines stated that all patients with IBD should be screened for malnutrition at the time of diagnosis and then regularly thereafter. And I would ask you to consider using the MUST tool, which is the only validated tool in IBD. So the MUST is a pretty simple tool. It takes into account BMI, unplanned weight loss, and this acute illness score. Now, the acute illness score was originally designed for patients who are hospitalized and looked at lack of oral intake, so patients being NPO for more than 5 days. And we found that this was not really relevant in our outpatient IBD clinic. So we published an article showing that we replaced this with a component of IBD disease assessment, looking at diarrhea and reduced food intake over the last 2 weeks. Any patients who are screened in our center who have medium or high risk are sent to our dietitian and our team, and they're seen by our nutrition team. These screenings can be done by your medical assistants at the time of vital sign assessment, so it shouldn't add too much to your visit. If that's not happening and you want to just look at the high value components, what do you ask patients for? You should look for unintentional weight loss in the last 6 months. Are they losing weight? What is their BMI? And are they having a lot of symptoms? If there's a lot of reduced oral intake, diarrhea, etc., it's important to know. You actually have to ask patients, we find, what are they eating? Because if you ask patients if they're eating normally, they may say yes. They may have adapted a new baseline of normal for them. But when you actually ask what that is, it may be skipping meals, only having tea and toast, etc. And so in summary, these are the pearls and pitfalls in IBD nutrition. And with that, I'd like to thank you. And I think we can open this up to the group for questions. I know there were a couple of questions for the others in the group as well. There's a question about ARFID, if we can go back to Dr. Pazer. If I ask for ARFID therapy for a patient, will the psychiatrist know what I'm referring to?
Definitely. So I would say this is a newer common diagnosis. So while it was developed 10 years ago, it's becoming very common now. We often start with a psychologist referral, so an eating disorder specialist, but psychiatrists are very well aware of the diagnosis as well and will be able to direct you.
Perfect. Thank you. There's a great question about hair analysis in terms of micronutrient status for patients with IBD. So this is a really interesting question. We know that the serum levels are very impacted by systemic inflammation, and they can be artificially high or low. And so therefore, yes, hair analysis has been studied. There have been 2 studies looking at zinc levels in hair. The question is, how do we reliably find testing algorithms for this and make this accessible for the community? So currently we've been looking at hair, saliva, urine, other forms of testing for micronutrients to see if they're less impacted by systemic inflammation. Hair analysis, the only important thing to consider is it can't be dyed hair. They can't have any hair dye. So that is something to take into account. And patients have to be willing to let you take usually a back hair for testing. But I think definitely for the future, something we're looking at. There's a question about, maybe Rose might be able to answer, what kind of shakes without lactose do you recommend for children with Crohn's and diarrhea?
Sure, yeah. So there are a bunch of lactose-free supplements on the market. The ones we typically recommend would be Owyn, spelled OWYN. I could put it in the chat. And Kate Farms. Those are both vegan and obviously lactose-free products that we definitely recommend, and our patients tend to enjoy them, which is a plus.
Perfect. There's a question in my chat here for Professor Ben Horan. Who do you consider your ideal patient for their use of CoQ10? Is there a specific patient that you look at and say, this is a great person who would benefit from CoQ10? I don't know. I see he's there, but maybe. Okay, we will keep going. There is also a question here for Dr. Kyle. Some patients who are pre-op from their subtotal colectomy may ask about restrictions and what they'll have with the J pouch after. So do you tell them that the diet will become more restrictive, less restrictive? How do you guide those questions when they're considering or maybe hesitant about their subtotal colectomy?
No, I think that's a great point, and I think that goes hand in hand with being proactive and actually seeing patients in consultation at that stage before they even embark on the pouch journey. In general, I don't think that a pouch diet, and Steph, correct me if I'm wrong, needs to be more restrictive than a general diet. I think it's all about figuring out what food triggers cause, what foods trigger which pouch symptoms, and just optimizing those foods. So I actually tell patients that they don't need to be on a very restrictive diet, if restrictive at all. They can continue to enjoy the foods that they've enjoyed in the past with slight modification. And a lot of it really ends up honestly being more texture modification. So a lot of patients get told by the physicians that see them in the hospital at the time of their surgery, whether it's on the medical side or the surgical side, that they can't eat fiber anymore. They can't eat salads. They can't have kale. They can never eat popcorn or carrots. And then they carry that on for many, many years. And I think part of what we do in the IBD center is we actually start to kind of break down all of those barriers and all of those limitations that they've been told about in terms of diet and help patients reintroduce these foods. So the short answer is I don't tell them that their diet is going to be more restrictive. I tell them that there might be foods that trigger some symptoms, but we can modify those foods, whether by texture or kind of portion, such that they can continue to enjoy like a very diverse diet and not overly restrict any one thing.
Absolutely, I agree. And I just want to actually bring up that point you said. Our patients hold on to these little things they're told. Somebody once told me not to eat popcorn. I hear this every day in clinic. I was told I can't eat lettuce. I was told this. So we need to be really careful about how we're educating our patients because they will hold on to that. And if you tell them that, let's say you're seeing a patient in the hospital, they hold on to that for a long time. And maybe 10 years later, they're still not eating those because they associated it
Exactly.
with that advice they had received. So making sure we're emphasizing this is for the short term if you are restricting or why you're restricting it in that time. Rose, there was a question about any resources or websites to share for recipes, tips for children.
Yeah, I can definitely share those. If you want to just message me your email, you can direct message me if you want, and I can get you some resources later today.
Fantastic. Professor Van Horn, are you here? Are you able? I'm not sure if you heard the question before. I don't think he's here. So we will get that question answered for you after. Are there any other questions? Rose, there's a question that was just sent to me about transitioning back to a regular diet. Are you doing that discussion in the hospital after a surgery, or is that happening after discharge with an outpatient dietitian?
Ideally, we want our patients to follow up with a dietitian outpatient. That's not always possible, unfortunately. So I try to run through sort of a brief, how they can really reintroduce foods back into the diet. My primary focus is like the 2 weeks following surgery and around 1 month following surgery. But I always, run through in general what they can expect for 3 months or so down the line. Definitely more focused on the immediate sort of post-op nutrition.
Perfect. Well, if there are no other questions, please feel free, if anything comes up, to send us an email. We really thank everyone for their participation today and for joining us. We are recording this and we'll get that sent out to you. So please let us know of any questions. And thank you again for joining. And thank you again to Erica for organizing everything. We so greatly appreciate it. Bye, everyone.